for you, there will be negative marks. So this is very clear. So the direct question for team D. Identify who is the spotter. Team E. Team A. Team B.
So the long stripes and
Okay, I'll give you that. That's the correct answer. It's a single strip sign which is seen in ischemic colitis. It's usually in mild to moderate type of ischemic colitis we get this single stripe sign. It's a watershed area, so it will give you that. So congratulations to team B. So they will get 15 points. So now the direct question to team E. Which of the following probiotic strains have the strongest evidence for efficacy in prevention of antibiotic associated diarrhea? Is it Lactobacillus rhamnosus, E. coli initial strain 1917, Bifidobacterium species and Streptococcus, Lactobacillus bulgaricus and Lactobacillus casei, and E. Lactobacillus acidophilus? Take your time and answer. Yes.
Option D.
Wrong. Team A. Pass. Team B.
Pass.
Okay. Team C.
Answer A, rhamnosus.
Correct. So I thought it would be a very easy one. So both only Lactobacillus rhamnosus and GG and Saccharomyces has got good evidence in prevention of antibiotic associated diarrhea. So 15 points to team C and nobody gets negative points. So the first round is over. Now we go into the second round. Team A, your straight question. In Haralson classification of papilla morphology, which is type 3? A. Protruding, B. Creased, C. Small, D. Ridged, E. Eccentric. Team A.
Sir, C, small.
Wrong. Team B.
Pass.
Okay. Team C.
D, ridged.
Wrong. So the correct answer is A. Protruding type. So this is the classification. So type 1 is regular, B is type 2 is small, which gets high chances for difficult cannulation and pancreatitis. Type C is protruding, again a difficult cannulation, and type 4 is creased or ridged. So team C gets negative points. Now the direct question for team B. When is heparin bed suction used in EUS F&B? A. Pancreatic tail mass biopsy, biopsy from GIST, liver biopsy, suspected neuroendocrine tumor, or suspected highly vascular lesion. Team B.
C.
Correct answer. So can you explain why? Okay, to get a good core and to avoid any clots, blood clots, we use this heparin bed suction in US F&B for the liver biopsy. So that's the correct answer. So for 20 marks for team B. Now a direct question for Team C. So using pH4 time analysis, the equivalent dose of omeprazole for onoprazole 10 milligram is pH4 time analysis is the duration for which the pH is more than 4. Team C.
Answer is B, 60 mg.
Correct. So can I give a round of applause for this? So it's 60 milligrams. So full 20 points. Next question. Direct question for Team D. It's a spotter. Think twice before answering. Yes, Team D.
So fish mouth appearance.
Yes, exactly correct. So it's a fish mouth appearance in yes, correct, IPM. So I'll give you that. So full 20 marks for Team D. Because of the excess mucin secretion as well as for the dilated pancreatic duct, this phenomena occurs, the fish mouth appearance of the IPM. Now direct question for Team E. What is false regarding the induction dose in IBD? The induction dose of various drugs. Vedolizumab 300 milligram in 0, 2 and 6 weeks. B. Tofacitinib 10 milligram twice daily for 8 weeks. Adalimumab 160, 80, 40 in 0, 2 and 6 weeks. Infliximab 5 milligram per kg in 0, 2 and 6 weeks. Which is false? Team E. Why? Can you tell the right dose?
5 mg.
Wrong. The option is wrong. Now we go to the next team, Team A. Pass. Okay. Team B.
Option A.
You can elaborate? No, the right option is C. So it is 0, 2 and 4 weeks usually. So that is the only thing. All the doses are all correct. In all the duration are all correct. Adalimumab we give in 0, 2 and 4 weeks instead of 0, 2, 6 weeks in infliximab and vedolizumab. So that's the only thing that is wrong. So Team A gets B get negative marks. Okay. So we come to the end of this second round. Can we have the scores please?
Team A is 0. Team B is 40 marks. Team C is also 40 marks. Team D is 20 marks. And Team E is minus 10 marks.
So there is a neck-to-neck competition going on. So let's see what happens in the next few rounds. So now we go on to the third round. Direct question for Team A. A 79-year-old man presented with second flare of ulcerative colitis. He was maintained on mesalamine 1.2 grams twice daily. Presently, his stool frequency is 5 per day with minimal blood. He has history of chest infections due to bronchiectasis, multiple hospital admissions for that. So now, what is the best option for controlling this ulcerative colitis? Team A, your time starts now. Think and tell.
We'll go with option D.
Option?
D. Prednisolone protein.
Wrong option. Team B.
Option C.
Why?
To give maximum dose of medicine.
Okay, why not other treatment modalities?
He's having prednisone. He's having not very serious, only 5 per day minimal blood.
Yeah, very good. So it's a mild flare only, not much of blood, and only 5 per day. And he was on lower dose of mesalamine. So the maximum dose we can give up to is 2.4 grams twice daily, that is 4.8 grams per day. So first you have to maximize the dose because he is having risk factors for any superadded infections, and also colectomy will be very difficult for his age also 79 and not necessary for the mild flare. So that's good. So team B gets the 15 points. So direct question for team B. The mechanism of diversion colitis that we do after ileostomy and colostomy is downregulation of chloride channels, lack of short chain fatty acids, change in the normal microbial flora, absence of normal flora of feces, excessive mucus production leading on to erosions.
Option B.
Option
B.
Lack of short chain acids. Very good. So the SCFAs are the main source of fuel for the colonocytes. So their deficiency is the main reason for the diversion colitis that we get after colostomy. Good. Next, direct question for team C. In gene carriers of FAP with colonic polyps, the lifetime risk of duodenal or periampullary carcinoma is 5 to 10%, 20 to 30%, 40 to 50, 75 and 100%. Think and tell. Team C.
Answer B, 20 to 30%.
Wrong. Question goes to team D.
Pass.
Pass. Team E.
It's option A, 5 to 10%.
Correct. So it's only 5 to 10% for the duodenal or periampullary carcinoma. Only for colonic malignancy it is near 100%. So 15 points for team E. Now direct question for team D. So listen carefully. So PBC patient without cirrhosis and who is on UDCA therapy and which is false can develop variceal bleed in grade 2 fibrosis itself, can develop ascites in grade 3 fibrosis itself, can develop thrombocytopenia in grade 2 fibrosis, can develop esophageal varices in grade 3 fibrosis, can develop cholangiocarcinoma in grade 2 fibrosis. Think, pause and tell. Yes?
So option E.
E.
Option E can develop cholangiocarcinoma in grade 2.
Wrong. The question goes to team E.
Pass.
Pass. Team A.
Option A.
A. Wrong. So they can develop variceal bleed. The right answer is B. They usually don't develop ascites in grade 3 fibrosis. They develop portal hypertension. This is based upon the nodular regenerative hyperplasia that can occur in patients with PBC even without cirrhosis. That can lead to portal hypertension. So these patients can develop varices, variceal bleed, thrombocytopenia and other things, but they don't develop ascites. And cholangiocarcinoma also can be seen even without cirrhosis in patients with PBC. So negative marks for team A. Now the direct question for team E. A 54-year male is diagnosed with short segment dysplastic Barrett esophagus. A repeat endoscopy was done in another center in which again 4 quadrant biopsies were done, but there are no nodules or mucosal irregularities in light endoscopy, and biopsies confirm again low grade dysplasia. What would be the next best management? A. Repeat EGD after 3 months, twice daily PPI and repeat OGD after 3 months, twice daily PPI and repeat OGD after 6 months with biopsy, RFA or EMR. So team E. Look at the question once more and then answer.
Option is
Wrong. the question goes to team A.
ISG PPA and repeat OGD after 6 months.
No. The answer is RFA because it has been confirmed twice. So this is the current guidelines. When we confirm low grade dysplasia twice, and if there are no nodules and mucosal irregularities, we go for RFA. So the answer is RFA. So negative points for team A. So now direct questions to team A. According to 2023 Puri guidelines for HCC, the contraindication for liver transplant, though the patient is within Milan criteria is if the Ballard score is more than 2, if the Ballard score is more than 4, if ALP is more than 1000 and the ALP is more than 500. Team A. Alpha fetoprotein. Alpha fetoprotein is more than 1000, alpha fetoprotein more than 500. Correct. So if the alpha fetoprotein is more than 1000, it becomes a contraindication, though it comes under Milan criteria because of the very high recurrence as well as high chance of metastasis. So they don't do liver transplant in these situations. Correct answer, full marks. Now direct question for team B. According to INASL guidelines, whenever systemic therapy is needed for hepatocellular carcinoma, what is false? Sorafenib can be used after atolizumab and bevacizumab failure. Atolizumab bevacizumab is the first line therapy. Nivolumab may be used as a first line therapy. Lenvatinib can be used after sorafenib failure. So which is false? Team B.
Option A.
Wrong. Team C.
Option C.
Wrong. So the correct answer is D. The first line therapy now they recommend is B, atolizumab and bevacizumab, and if it is not available, sorafenib, lenvatinib may be used as first line therapy, but not livolumab. Okay. Okay. There is. Okay, that is false. So the team C gets the full points. So nivolumab may not be used as a first line therapy, and when one group of drugs fails, we can use the other group of drugs as the second line therapy. So team C gets the full points. Okay, past question, 15 points. Now team C, direct question. Regarding fundy gland polyps, which is false. It occurs in attenuated FFP syndrome, occurs in chronic PPI use, seen in 10% of all endoscopies, needs colonoscopy to rule out polyps, occurs in Zollinger-Ellison syndrome. Team C.
E.
Wrong. Team D.
Needs colonoscopy to rule out polyps.
Yes, that's the right option. So it doesn't require warrant colonoscopy to rule out polyps in all cases of fundic gland polyps. It occurs in all the other conditions: attenuated FAP, chronic PPI, and Zollinger-Ellison syndrome. So full points for 15 points for team D. Now direct question for team D. According to ISG guidelines for foreign body, there are three categories. There are you can see non-emergency endoscopy, endoscopy within 24 hours, and emergency endoscopy. So regarding that, which is false? Non-emergency endoscopy is done for disc bacteria in stomach. Endoscopy within 24 hours is done for magnets in stomach. Emergency endoscopy is done for sharp objects in stomach. Non-emergency endoscopy is done for coin in esophagus. Emergency endoscopy is done for disc bacteria in esophagus. So take your time, think and tell which is false. The question is which is false.
false, right?
Which is the false?
So option A, non-emergency endoscopy is done for distal
Wrong.
stomach.
Team E. Team E.
Option C.
Correct. How, and can you explain that?
You emergency. It doesn't come under the criteria of emergency.
Okay, good. So it comes under the criteria for endoscopy within 24 hours. Though if you take in the face value, it appears right. According to the guidelines, what they tell is, it's not comes under emergency endoscopy. It comes under the category of endoscopy within 24 hours. So if you see the second column, so 15 points for team E. That's correct. Team E, your direct question. A 40 years male underwent endoscopy for reflux features, 1.5 centimeters submucosal lesion in antrum. Histology of EUS biopsy is shown below, and which is the best management? A. STER, B. FTER, C. ESD, D. Surgical resection, E. EUS surveillance. Team E.
Option C.
Wrong. Team A.
Pass.
Team B.
Pass.
Team C. Yes. Yes, you can tell.
Option E.
Right. That's the correct answer. Because it's a spindle cell tumor gist which is small in size, the current recommendation is to go for EUS surveillance. So that's the right option. So team C gets 15 points. So we come to the end of round 4. So can we get the scores, please? I think again there will be a neck to neck competition.
For team A, 0 points because they have 2 negatives and 1.
Okay.
Team B, 75. Team C, 70.
So increase them with a good round of applause, please.
Team D, 35. Team E, 20.
Okay. So there is a healthy competition going on between two of our first and second places and third and fourth places. Let's see what happens in the final round. Now the direct question for team E. So usually we reverse it in the later parts of the quiz. So first question will be for team E. So yeah, this is the last one. Yes. Team E, it's a 8 centimeter gist in stomach, and the patient has received 6 months of neoadjuvant imatinib. And now, which is the best test to assess the response to therapy before surgery? EUS, somatostatin receptor scintigraphy, FDG PET scan, Dopanac PET, MRI. Team E.
Option B.
Wrong. Team A. E is elafibranor and dulaglutide. Team A.
Option D.
Correct answer. So you are up to date. So these two drugs have been approved in this month. Denifansine is a fatty acid synthase inhibitor, and survodutide is a glucagon GLP dual agonist. How did you come to that? You ruled out other things. Okay, anyway, good. So full points for them. So we have come to the conclusion of the quiz, and any guesses who will be the winner? Okay. Can you bring the questions? And I request our TNISG secretary. Okay.
It's a tight one. Team A.
So shall we tell the? Okay.
Team A 35 points. Team B 95. Team C 100.
So it's a very tight competition, 95 and 100 points. Congrats to both the teams.
Team D 35.
Okay.
Team E 20.
Okay. So team D gets the third place. Congratulations. Thank you, one and all.
Both are 35.
35. Okay. To team A and
Team A 35. Team D 35.
okay. So we will go for a tiebreaker between team A and team D. Can you just two questions, please? Can you switch it off for a second? Yeah. Switch off the screen for a second. Okay. So the rules will be again the same. So two questions will be given. Again, the pass will be there, the negative marks will be there. No, only for A and D. No, other teams are. Okay. Question for team D. Yeah, can you open it? Yeah. So 55-year-old lady has presented with recurrent GI bleed. Again, it's coming. Okay. Recurrent GI bleed and anemia, and observe the lips. What is expected in the GI evaluation? Hamartomatous polyps, adenomatous polyps, telangiectasias, neuroendocrine tumor, GIST. Wait, pause and tell.
Option A, hamartomatous polyps.
Wrong. Team A. So telangiectasias. These are all the small telangiectasias that are seen in the lips. So this patient had a recurrent GA bleed. So she had, she's consistent with HHD, Osler-Weber renal disease. Multiple vascular malformations occur in the GI tract. So this is a case of HHD. So now the question goes to team A. If you answer the question correctly, you will be getting the prize. So keep that in mind. So this is the diurnal biopsy of a patient with chronic small bowel diarrhea and identify the pathology. Okay, correct answer. So these are the small giardia which can be seen within the lumen. So that's the right answer. So team A gets the third prize. Congratulations.
Thank you, participants, and thanks Dr. Arun for organizing a wonderful quiz program. So students may now go for breakfast and then continue with the program. Thank you.
The abnormal lab values include 10 to 20-fold elevation of the aminotransferase level and elevation of the alkaline phosphatase level more than the normal level of those in the pregnancy, and the bilirubin elevation are not less than 5 mg per deciliter. The liver histology in the patients with preeclampsia shows hepatic sinusoidal deposition of hydrate along with periportal hemorrhage, liver cell necrosis, and in severe cases an infarction. These changes are likely to have been due to the vasoconstriction of the hepatic vasculature due to high blood pressure. The microvesicular fat infiltration has also been observed in some cases of preeclampsia, suggesting the possibility of overlap between acute fatty liver of pregnancy. The maternal mortality of preeclampsia and eclampsia is rare in developed countries, but may approach 15 to 20% of developing countries. Likewise, the fetal mortality is rare, occurring around 1 to 2% of all births. The only effective treatment for preeclampsia is delivery of the fetus and placenta. The HELP syndrome, as we all know, the hemolysis, elevated liver enzymes with low platelets in the pregnancy involving due to hemolysis. About 70% of the cases occur antenatally during the last trimester of the pregnancy. Most patients present with right upper quadrant abdominal pain, vomiting, malaise and edema and significant weight gain when they are coming for follow-up. And the precise criteria for HELP syndrome are necessary for research purpose as well as for the treating purpose and requiring the maternal medical complications. We require the presence of all these criteria, the TNC criteria, the microangiopathic hemolytic anemia, characteristic histiocytes, also called as helmet cells on the blood smear. Other signs suggestive of hemolysis include an elevated indirect bilirubin level and low serum haptoglobin level concentration. The platelet count are less than 1 lakh cells per microliter, and the bilirubin level is more than 1.2 gram, and maximum it may go up to 20.5 micromole per liter. The serum AST levels may increase 2 times the upper limit of normal. Most of the time we see 3 to 4 times the upper limit of normal. The liver histology in a preeclampsia case involve the intravascular fibrin deposition and the sinusoidal obstruction that can lead to hepatic hemorrhage and infarction. Histologically, one may see focal hepatocyte necrosis and periportal hemorrhage and fibrin deposits. The liver-related complication which we come across even after the delivery or the hepatic infarction, hepatic rupture, and hepatic hematomas, both intraparenchymal and the subcapsular. Most of the time, the preeclampsia patients may present with severe abdominal pain on day 1 of the delivery. Should be investigated for the ultrasound development to look for the collection of the blood under the capsule of the liver. The right lobe is more commonly affected than the left lobe. The reported maternal mortality for HELP syndrome is 1% and perinatal mortality rate ranges from 7 to 22% and may be due to detachment of the placenta, intrauterine asphyxia and prematurity. The only developing treatment for HELP syndrome is delivery. The pregnant woman is greater than 34 weeks of gestation, immediate induction is recommended. If gestation age is between 24 to 34 weeks, the corticosteroids are administered to accelerate the fetal lung maturity, and in preparation of the delivery maximum within 48 hours if we cannot control the blood pressure. The lab value should be normalized once the patient has delivered the baby. So this becomes more important. Identification of the patient preeclampsia and HELP syndrome relates more on the lab values like urine analysis, fluid blood count, liver enzymes, liver functions and creatinine, and monitoring the patient are mainly with the BP, proteinuria and abdominal ultrasound and risk satisfaction of the patient, as well as stabilizing the patients so that the blood pressures are within control, either with labetalol, nifedipine or levodopa. So that, and if the gestational age is less than 34 weeks, to go for corticosteroids or directly go for the termination of the pregnancy. The patient is having less than 34 weeks, then they can be given the magnesium sulfate to reduce the BP before moving for the termination of the pregnancy. So the optimal treatment will be delivery of the baby. So the patient should undergo normalization of the values within 48 hours. The acute fatty liver in pregnancy is very rare and occurs in 1 in 1000, occurs usually in the 3rd trimester. The presence with nausea and vomiting, abdominal pain and fatigue. The jaundice occurs frequently and in some women present with hypoglycemia, hepatic encephalopathy and coagulopathy. The lab findings shows the aminotransferase levels are mild to severe. So it depends on the mitochondrial beta fatty acid oxidation, accumulation of the fatty liver and resultant in the injury. The histopathological examination reveals in the liver cells shows a swollen pale hepatocytes in central zones with microvesicular fatty infiltration that can be identified only in the frozen section with oil red staining with mitochondria and paracrystalline mitochondrial inclusion bodies. So many a time we may not be doing the liver biopsy, it is only identification by clinical. As with most pregnancy associated liver disease, the treatment of AFLP involves the delivery of the fetus. In that case, the patient will grow up to acute fulminant hepatic failure with even a need of transplantation, and the patient should be referred for earlier transplantation if needed. AFLP has a maternal mortality rate of high rate of 18% and a fetal mortality rate of around 23%. associated liver disease, the treatment of AFLD was the delivery of the fetus. The intrahepatic cholestasis of pregnancy. The intrahepatic cholestasis of pregnancy occurs in late second or third trimester and has prevalence of about 1 in 1000 to 1 in 10,000. The mutations in phospholipid translocator known as ATP acid transporter B4 or multi-drug resistant protein are associated with the development of ICP. The estrogens come to act as a hepatocyte by decreasing the membrane permeability and bile acid uptake by the liver. The maternal to fetal transfer of bile acids across the placenta, it becomes impaired, leading to potentially toxic levels of bile acid in the fetus. The classical symptom is usually pruritus that usually begins even in the second and third trimester, and many patients may miss it. It usually occurs in palms and soles and may progress to rest of the body. The pruritus often worsens at night. The bilirubin levels may be elevated but usually less than 6 mg per deciliter. The prognosis of the women with ICP is usually good, but it is associated with increased fetal morbidity, with particularly chronic placental insufficiency, fetal distress and intrauterine death. So how to manage the abnormal elliptic pregnancy? So the liver disorders are unique. They range from clinical presentation to life-threatening cases. They need to be differentiated from liver disease of pre-existing or the present liver, or the timing of the disorder should be planned for the pregnancy continuation or to discontinue. Since the liver biopsy is not feasible even in the indicated disease, the clinical criteria have to be developed for diagnosis. So it is a gross approach for the liver disorders with the ICP or the acute fatty liver pregnancy, how to handle. So the patient should be on follow-up of the bile acid levels, and the bile acid levels should be maintained less than 20 millimoles to 40 millimoles until the pregnancy. The patient can be started on UDC and can be continued till termination of the pregnancy. So how to prevent the jaundice while in the pregnant or stay on the alcoholic pregnancies in the females, and speak to the obstetrician and gynecologist and getting a vaccination against hepatitis, while sharing of the personal hygiene, schedule the routine doctor visit and maintain a healthy diet and healthy one. Thank you.
Thank you so much, ma'am. For our next session, we will be having Dr. Nirmala ma'am, who will be speaking on the topic approach to child liver disease. Who is a professor in an ICH Chennai.
Good morning, my dear teachers. My dear friends, very good morning to all. First and foremost, I would like to thank Professor Kadasamy and team for inviting me to this excellent video and hosting this. Thank you so much. The topic is very vast. I try to cover in 10 minutes, and the chairpersons have the liberty to stop me at any time. As far as childhood liver disease, it's a spectrum which ranges from neonatal, that is polycystic, that is a polycystic in the newborn, to liver failure in the adolescence. Going to the first case, this is an 83-year-old male child was born of non-consanguineous parentage. History of eye-colored urine and pale stools and prolonged bleeding from the injection site, and incessant crying with abdominal distension. All the child was thick, pale and expressed. All these things are history of cholestasis. What we have to understand is the children generally in the newborn always present with cholestasis or any type of injury. So that will be the presenting manifestation. So it's up to us to find out the cause for the cholestasis. So whenever a child comes with cholestasis, an infant newborn comes with cholestasis, the most important thing is the color of the stools, and whether the child is sick or a well child, or what the weight gain, the consanguinity in the family history plays a very important role, and also the associated features and the complication associated with vitamin deficiencies like that. And always look for clinical clues pertaining to the liver disease spectrum. and biochemistry and imaging may be helpful to a certain extent. So by definition, renal colitis is a group of disorders characterized by colitis, which will mean that there is jaundice and ictal urine with or without pain stones. And biochemically defined as direct bilirubin more than 1 milligram or more than 20% of total in any children type beyond 40 days of life. It's quite common, 1 in 2,500 diapers. As far as once you see a child with cholestasis, as I said, for the two most important things are that look for the color of the stool by yourself. That is mandatory. In addition, you have to see if the child is sick or not. If the child is got a pale stool, then your first choice will be an abdominal ultrasonography to rule out surgical causes which are treatable. If the child is sick, then you will have to go for what are the treatable causes of urinary causes like urine and for galactosemia, letter urine cultures for sepsis, and blood staining if one of the common causes for this is also treatable, and alpha-beta protein thalassemia where diet and drug are available for treatment. All these treatable causes have to be ruled out, and as in a bar footing before going for the further. Once child is not sick and the stool is not big, then you have to go for we can reduce the pace of investigation and go for either C3 weeks pneumonitis or biliary atresia. Liver biopsy is a very important group which depends upon the age of the onset. We can place it one child. The child present between before to 60 days, liver biopsy we have very used up to even up to 90 days. But beyond 90 days, when they present, the liver biopsy may not give very useful information which you need. So the whole workup is mainly directed towards either the surgical cause or non-surgical cause. The surgical cause actually is straight for surgery, especially when it is before 60 days, so that the child will be benefited. Generally, there is a delay in blood flow. That is the reason for the adverse outcome in all these children. So, what are the causes for the delayed blood flow? Generally, most of them they think that renal jaundice is generally due to physiological jaundice, and they don't fractionate. Fractionating is very important. Similarly, because this due to cholestasis, the response to vitamin K, the only thing is similar to the newborn. And similarly, they confuse between physiological jaundice and conjugated bilirubin. So sometimes there will be a false, if there is a false in the bilirubin, it will fall in the bilirubin, which they think the child is recovering and may discharge the child. This is one of the few reasons why we miss the cases early. Going on to the second case. Second case is this case about a neonatal liver failure, which is very common nowadays, recognized and even treated nowadays. This is a female infant who was underwent illness. The mother underwent illness is 32 weeks with a birth weight of 1 kg. That is preterm and low birth weight child. And antenatal, the child has been diagnosed with intracranial growth depression and severe oligohydramnios. The parents were not non-consanguineous. The child had a very strong development. The child had to be intubated and had recurrent hypoglycemia, cholestatic jaundice, ascites, hepatomegaly, and GIP. Examination of the child showed the child had ascites. And it just showed that the child has anemia, thrombocytopenia, and abnormal liver synthetic liver functions, elevated ferritin and abnormal iron filings are clue towards the diagnosis. Abdominal ultrasound shows that there is ascites and there is liver fibers are altered. Ascite fluid suggests of portal hypertension, and so this time, because the non-consanguineous parentage and all in spite of being all the etiology workup towards inborn metabolism were done, but they were all negative. So liver failure is a unique disease that differs from adults and are also known as that in regard to etiology, management, and prognosis. It is defined as in any other liver failures, but they are defined as coagulopathy more than 15, prothrombin more than 15 seconds, INR more than 1.5, which is not corrected by vitamin K in the presence of encephalopathy. So if there is no encephalopathy, VT more than 20 and INR more than 10 is the diagnostic addition. They should have biochemical of liver injury and also absence of liver disease. But as far as encephalopathy, whenever you define encephalopathy in newborn, the criteria differs. This is based on the weighting list criteria where the stages depending upon what are the symptoms usually occurs in the newborn. So this is a simplified algorithm for the acute liver failure in neonates. Neonates, the common causes for liver failure in neonates are the most common infections, especially the viral infection. The next most common is hypoxia injury. Then what I am trying to portray is that gestational autoimmune liver disease, which is an immunological mediated disease like an RH ice immunization, which can consider as liver disease in the newborn. This is the case which I am talking about today. In addition, we can have other metabolic causes and also as a cause for liver failure. So whenever you see a neonatal liver failure and you suspect gestational liver disease, you have to look for the clinical scenario and the diagnostic criteria is based on the demonstration of extrahepatic iron stores, especially in the minor salivary glands by buccal biopsy, or you can do MRI. But all these things fail, the liver biopsy may help. Only why you want to diagnose this, because once you diagnose, we have treatment in the form of exchange transfusion and IVIG infusion. This is the presentation of the guard. The other, as for the other cause of herpes infection, that is the present genetic enzymes and multi-organ involvement. And even in mitochondrial hepatopathy, there is a multi-system involvement, and you have to know that it's not a candidate for liver transplant, except when they are present on isolated liver disease. Other causes are tyrosinemia, galactosemia, and HLH. HLH, they got rapid criteria, and this also has got chemotherapeutic agents to treat HLH, so as to prevent the progression of the disease. This is a 1.5 year month with abdominal distension and seizures, and family and consanguineous parentage. On examined child had chubby cheeks with massive hepatomegaly without a spleen, and with mild growth foldering. So isolated hepatomegaly in children generally, like in like adults, there are other causes. But peculiar to children are the story disease, like the glycogen story disease, and development anomalies like the congenital hepatic fibrosis, Rodney's disease, polycystic liver disease. And as far as benign tumors are concerned, MLG is very peculiar to the children. Malignancies are commonly seen as hepatoblastoma, which CCC and inflammatory can also occur in children. The labs, especially the liver biopsy, may be used to, especially in the case of GSD. This child had hepatocytes in GSD looks like a plant cell, like because of the thick appearance of the cell wall. And this child, now with the widely availability of the genetic testing, now we have done a genetic testing, confirmed as glycogen 6. Previously, we thought only the glycogen 1 and 3 were common, but now with the availability of genetic tests, we know that glycogen 6, 9 are as common as 1 and 3 in children. This is a child. This child present with vitamin deficiency, predominantly bleeding, and this one follow up in the hematology department. Then this subsequently developed decreased vision and mild abdominal distension, where we are able to pick up a firm liver. So we thought that this might be something else with the liver disease, and then the child also had white hot spots. So whenever the child present with vitamin fat soluble vitamin deficiency, we have to think of cholesterol liver disease, pancreatic deficiency, or other causes. This child, in addition to vitamin deficiency, also had a firm liver with lot of associated liver disease. And we went with the workup. The only thing which was finding in this child was a very low GGT. A cholestatic disorder with very low GGT, generally we think in terms of PFIC and other different diagnosis of bile acid synthetic defects. This child, because the low GGT, we went on with the bile acid. Bile acid was very low, that is less than 1. So suggesting bile acid synthetic defect, we did genetic testing that confirmed to be bile acid synthetic disorder. So this why this can be easily treated with. We thought that this all actually this very highly the mortality is very high case of VSD, but now with vitamin supplementation and folic acid is available in India now. The child is doing well. We are waiting till to go as far as possible with the native liver. This is a 10-year-old child presenting with liver failure. There is chronic decompensated liver disease. Whenever a child comes with chronic decompensated liver disease, with adolescent age group, the most common cause can be only first thing we have to throw to Wilson's, even if there is no consanguinity. Other cause could be infective autoimmune inherited. I'll summarize. So this child 24-hour copper was fine. Nowadays 24-hour copper we don't do a challenge. We only do for without challenge, which is more than 100. It's suggestive of Wilson's. And in addition, we have done a genetic testing. So nowadays genetic testing has started doing. Most of them have become positive for genetic testing. And finally, this child present with vomiting blood with UGA bleed with hepatosplenomegaly, suggestive of a port epilepsy bleed. Whenever we have port epilepsy children, pre-hepatic cause the commonest cause is extrahepatic portal substitution. In addition, in the intrahepatic, as we already mentioned, non-cirrhotic causes like congenital hepatic fibrosis common in the younger children. The rest of the causes are like that in of adult. In this child, in a child with UGA bleed, there is such of varicose bleed. The most important dimension is ultrasonogram, where you can pick up the portal cavernoma. When you have portal cavernoma, it's full of intrahepatic cause. You know that it's extrahepatic portal substruction. This child, the different presentation, the child had history of progressive jaundice in the neonatal period also, and then now the child had features suggestive of a chronic liver disease, and then so we because we are not able to complete even with the liver biopsy, we have ended with genetic testing where we are able to find out neonatal chronic sclerosing cholangitis. Before we thought that this doesn't propose to adult. Actually, this neonatal sclerosing cholangitis actually is present only in older age group as port tendency bleeding, and they decompose very late. So actually they can manage with the native fever for a long time. We are able to manage the port tension. After the genetic test, we went on with the MRCP, which showed sclerosing cholangitis. Now the child is on supportive care. So summarizing in the conclusion slide, childhood outcome is a very big spectrum of disorders. Though in adults it's only etiology evolves around the alcohol, viruses and MAFL. Children, the liver disease really becomes a very big spectrum of disorders. And age and treatment is very important that it is the etiology and the line of work. Always you have to look for certain clues which can help you with the diagnosis. Liver biopsy is very important in liver disease children because they might give a clue and sometimes they can rule out other disorders. And genetic testing nowadays plays a very important role in the diagnosis because early diagnosis is the key for the appropriate treatment. Thank you.
Thank you for your astonishing speech, ma'am. Food is not just a fuel, it's information, it talks to you daily and tells us what to do, said by Dr. Mars. Now let's welcome Dr. Thirumal sir, who is the Associate Professor of Gastroenterology, ISG Institute of Coimbatore.
Good morning, teachers and others. First, I like to thank Kandasan sir and Poppy madam for giving me this opportunity. So, I was asked to talk about food allergy. It's a very broad topic. I try to concise and give it in this format. So, just an overview of food allergy, what is the real life experience we face, and with some carry-home messages. So food allergy disorders happens in only 3 systems of the body that is exposed to the environment, that is respiratory system or GI system or skin. So these are the common 4 food allergy disorders. Out of this, food allergy is the least one. As you see, it's more in the pediatric age group and it vans out as the age increases. So it's an immune-mediated reaction, and for this diagnosis needs evidence of sensitization and symptoms occurrence on the exposure to the food. So often this food allergy has been confused with all form of adverse reaction to the food. So what we encounter more is the food intolerance. So what we encounter more in clinical values of more of food intolerance, it's not food allergy. So what we truly mean of food allergy is only these 3 groups. One is IgE mediated, another is non-IgE mediated, another is mixed food. And celiac is also immune mediated, but it's a different clinical degree. It is out of scope of our talk. So we will confine only to three groups of food allergies. So as told, its incidence is very low. Its global incidence is around 4.3%. More in the children, it's around 2.4, and adult it is 1.5. And it's more in the West. And in India, it is very minimal of only 0.14%. So, but its incidence is keep on increasing due to our changing food habits and like environmental changes. These are the common food allergens that have been encountered. And in the West, the most common is the cow's milk, and in the children, and in adult, it's most is the shellfish. But in Indian population, from this eco-travel study that is conducted in Mysore and Bangalore, our most common food allergens is the wheat, and both in adult and children, and it is having more sensitization, but you see the probability of occurring of allergy is very, very minimal. So this is the common mechanism where primary is the failure of the oral tolerance that leads to inappropriate type 2 helper T cells predominant response that giving to type 1 hypersensitivity. So coming to first group of drugs, that is IgE mediated food allergy. It is diagnosed when there is symptoms of occurrence within minutes of exposure and should occur within hours. So these are the various manifestations involving skin, GIT or respiratory system. If more than 2 systems is involved, along with respiratory compromise and gastrointestinal or respiratory compromise or circulatory compromise, it is called anaphylaxis. In that case, we have to directly ask them to give them intramuscular adrenaline injection, and you have to assess the response. If it's not responding, you have to give the second dose also. Giving alone antihistaminic and steroids is not sufficient. It's not a life-saving drug. So these are the batteries of tests that is available for the diagnosis. I'm not going to go in detail due to want of time. So basically, the ideal approach is if there is history of food allergy. Ideal test is the oral food challenge, but it is a cumbersome test. Then you can go for skin prick test where the allergen is put on for flexural aspect of food, and they lancet through the nasal needle. It is picked and see the appearance of wheat. Or you have to go for specific IG test, or you go for specific elimination. But in real life, we are not able to do this in this process. We go from this process. So start with the elimination of the common food allergens and see the response. If it is there, based on that, we go for the other quantitative tests. These are the new novel tests that has been in the experimental stage. So these are the methods of the food allergy test. So you can see that the elemental diet is the one that having more therapeutic and diagnostic efficacy. So that is the one that being started now. So coming to management part, so food avoidance and allergic education is the one that is foremost, that is important. And as to be patient should be prepared of the exposure. They should be having adrenaline auto injection. But in India, unfortunately, we don't have the adrenaline auto injection. We have to ask the patient to keep the adrenaline in the insulin syringe and keep it with them, and we have to replace every monthly. So these are the new treatment that is being available where you induce the tolerance of this allergen by giving the drug either by orally, that is OIT, or by sublingual or epidermal. But in nowadays, children's, it is tolerated only in the children's where you can give in the oral form. Next is reintroduction of food in the stepwise manner, that is started giving the least allergic drug to the most allergic drugs. Most allergic food. Next group is the non-IG mediated. Here it predominantly occurs in children and it is not less recognized in the adult. So these are the three groups that has been found. One is enterocolitis, another is proctocolitis or enteropathy. Enterocolitis presents with septic shock-like symptoms. They respond very well to the fluid management and they have recovery within the stoppage of exposure of the food. And they have the chance of getting further later years chance of developing IG mediated food allergy, and by 50% of child will develop tolerance by 1 year of age. Second group is the proctocolitis. They present with bleeding PR and they also respond, 90% will respond with the further bleeding if you eliminate the diet. Third group is the enteropathy where they present with chronic diarrhea or failure to thrive. They respond to hypoallergic drug and that also rarely manifests beyond 3 years of age. Third group is the mixed type. In that we have two broad groups. One is cow's milk allergy, another is the eosinophilic GI disorders. So cow's milk allergy has both IG and N. They have broad spectrum of presentation from anaphylaxis to the respiratory and other dermatological problems. I am not going to detail of this one. So this is the consensus that is developed by Iswagan for the cow's milk protein allergy. So they found that sometimes it is also overdiagnosed. In order to avoid that, they tell that to confirm the diagnosis of cow's milk allergy and to avoid overdiagnosis, you have to do oral food challenge after a short time of diagnostic elimination diet. These child over by 2.5 to 5 years develop tolerance and they can overcome the allergy by mostly by 5 years. Second group is the eosinophilic GI disorders. This is diagnosed based on these clinical symptoms of recurrent GI symptoms, presence of past or family history of allergy and peripheral eosinophilia, and they are confirmed by doing endoscopic biopsy and you have to evidence the presence of tissue eosinophilia. Based on the site and number they have, we have all these 4 groups. Provided we have ruled out the secondary causes of gastrointestinal eosinophilia. So this is the algorithm showing that management. Basically it is the management of food avoidance and start of induction by using steroids and has to be tapered over 4 to 8 weeks. If it is not responding or relapse, we can restart or we can go to higher drugs. So coming to our real life experience, for the past 2 years, we are able to encounter around 61 cases of allergy disorders. Out of these, IG mediated is very low, it's not much. Non-IG is around 9 cases. We have seen proctocolitis in around 7 cases, one having eosinophilic colitis, one having enteropathy. And we see more of mixed type, so around 52 have mixed type, out of them more have increased IgE level but not presence of tissue eosinophilia or criteria to fulfill the eosinophilic gastroenteritis. So any child with chronic abdominal pain, we found that they will be often labeled as functional disorders, functional abdominal pain. So, but many patients with abdominal pain with mesenteric adenitis on ultrasound, if you do, they can find the increased IgE level. They have food sensitivity is there. And then if you avoid them with the 6-food elimination diet and other supportive with anti-inflammatory or montelukast, we can prevent that one. Some are presented with blood in stool, some also in constipation. So these are some of the pictures. Most common we see the terminal mucosal nodularities. That is in the terminal mucosa, or you can see the erosions in the rectum, or sometimes ulcers also is there, or this is the feature of mucosal nodularities. So any patient with terminal mucosal nodularity, most common is the food allergy, where you have the diagnosis of lymphonodular hyperplasia. So we had to chair one non-responders who had not responding to other, and he found to have increased eosinophils. So we thought of hypereosinophilia, and we also ruled out the hypereosinophilic syndromes and mutation analysis. That also negative. So we did endoscopy and colonoscopy, shown out to be duodenal and also tissue eosinophilia in the colon. So it has involved both the upper and lower GI. Started with steroid, and he responded very well, but had asymptomatic for 2-3 months. Then he had relapse. So since he had recurrent relapse, we again repeated the colonoscopy. Now we show that same patient now it become having more mucosal nodularity, and this time is biopsy prone to be Crohn's disease. So there is overlap between esophageal GI disorders and IBD. So whether it is a overlap or is continuum, we have to have a debatable topic. So and it has been also documented that child with IBD has associated food allergy around 30 to 40%, and any patient with IBD, so who have new onset of weight loss or some dysphagia and rapid dose escalation, we have to rule out EB. So this is the carry home message I want to carry. So all food reactions should not be called as food allergy. There is a definite distinction between food allergy and food intolerance, and prevalence of food allergy is on rise, and its clinical spectrum ranges from anaphylaxis to chronic non-specific symptoms. We have to rule out eosinophilic disorders and lymphonodular hyperplasia before coming as functional GI disorders, and you should include serum IgE as a basic investigation evaluation in the patients all who are presenting with recurrent non-specific GI symptoms. Food elimination is the standard of care, and who are not responding to, in case of either IBD or eosinophilic disorders, we have to do other causes. Like in eosinophilic disorders, treating as eosinophilic disorders, who is relapsing or not responding, we have to rule out IBD and vice versa. Thank you for listening.
Any questions from the audience?
This is only comments. Pregnancy, old age, very different are big issues for any gastroenteritis or pediatrician. Pregnancy with cholestasis, fetus, newborn have to be taken care of because you have to suspect progressive familial intrahepatic cholestasis. That is a comment for carry home message. The second, madam was almost like Vande Bharat speed. She can be little slow and I am Mati sir. Slow the message is big liver differential diagnosis is always an issue. So fatty acid, liver gotcha. Then the second one, my fellow wanted to do a liver biopsy. I was on leave for 2 days. Then I came back, he waited for me to give permission. I just examined. They were dilated cardiomyopathy with congestion. It's a contraindication. So clinical medicine has to be given importance, never depend on lab. That's a very important message I want to reiterate. The second child, big liver was an issue. We had a department discussion that turned out to be vaginal. The third most important thing, congenital hepatic fibrosis. The last one, most important, is a big liver, could be a fatty acid oxidation. 4 conditions have to be differentiated in children. My friend ISG sir, just wanted to suggest you, there is no specific test for food allergy. Don't depend. 200 allergens are there in us. And the report will come as we are enriching only the lab. No investigation is diagnostic aspect.
Yes.
Yes,
That's a limitation.
modified Goldman's criteria. 3, no. We are giving patient who is allergic, give a medicine. No, he is already on medicine. He has come to you. There is no need for re-challenge. So remove it. Perfect. After 1 year, you re-challenge, he reproduces the same thing. That's all. I would like to ask you, what is the gap between the challenge and re-challenge and the withdrawal? That's always the issue. So 1 year, you will have to wait. The intestines not only are already having a damage, they have to regenerate. What is the regenerating drug that you can give? Zinc in children. If you give zinc for 14 days, 10 milligram below 6 months, 20 milligram above 6 months, that gives you good safety for another 3 months. They won't get recurrent diarrhea. This is what is most important. Peanut allergy is very rare. Fish is also very, very rare. Milk. You need to denote even celiac disease in these people. That's what I wanted to just give you. Thank you.
It's a nice presentation earlier, so just wanted to tell you, possibly it was not truly an eosinophilic disorder to start with.
Yes.
So there are two things like, like number of eosinophils you showed about 20, 30 and all that. Maybe low down, it may be very low. It should be at least 50 or 100 and all that. But I feel more than that, very cryptic eosinophils have to be always looked at. Maybe it was a Crohn's, because even in Crohn's we see the eosinophils there. So maybe.
So that only needs to be followed up rather than develop ICD or those things.
Absolutely point well taken.
I just clarify. Pediatric food allergy. If it is going to be outward protein allergy, the infant will have unaccountable bleeding pattern. Simple bleeding pattern. No mucus, no muscle sensory. Even IgE may be negative. Need not be. As you said, rightly pointed out, it is all only developing after milk protein allergy. You need to differentiate it from lactose intolerance. That's an issue. The most important, we do a simple proctoscopy on simple. You see at the sulcers. Take a biopsy. 25 eosinophils per hypo field. These are all academic. I will not do. I will remove the milk temporarily. Even for DOR, GERD in babies, there is 40% incidence of conflict protein allergy. This is one of the diagnostic tests, what is called therapeutic test. You remove the milk, the child becomes better from GERD, infant. Will it better?
Dr. Kumar, I have the same patient like you, sir. Case of eosinophilic ileocolitis, under follow for last 10 years. Would have done at least 3 or 4 colonoscopies. Every time the biopsy reported as eosinophilic ileocolitis. He does very well with steroid, taper, stop. And how to maintain the remission? Do you have any?
No, this patient we started with azothioprine and he's responded very well.
Shall we put them on azothioprine?
Yeah.
Question to Dr. Kavita. Dr. Kavita, madam. You mentioned mortality of HELP syndrome less than 1%. But practically, most of the patient, antenatal women with liver disorders present with combined features of HELP syndrome with high BP, with elevated alkaline phosphatase. Most of the physicians doing private practice, they refer patient to teaching institution. The mortality is very high, madam.
But actually, the mortality is very high in our population. Sir. From this data I have taken from ESL guidelines, sir, which was published in last year. So in that they have given only different numbers. But what we practice in our hospital is totally different. What is given from the different criteria. But we do see lot of cases. What they say is most of the time the pre-eclampsia and eclampsia is overlapping with ACLP, which is often missed, and that is a cause for the death of the patients. So only even in my slides I have told when we come across the HELLP syndrome to rule out the AFLP also. Sometimes which may be undiagnosed and may be causing more danger.
Is there any role for liver transplantation?
Sir, in HELLP syndrome they did mention about most of the time the liver transplant, because most of the time when we terminate the pregnancy, most of the time within 48 hours the patient is going to become normal. But whereas in AFLP there is a possibility the patient may go for the liver transplantation. They told the expedited delivery itself to be taken to the higher referral center, and where patient can undergo immediate liver transplantation with their family members is also possible, which is being done. But we are not doing so I have no idea about this.
Kavita madam, it was a nice presentation, madam. In our institution also we have a lot of cases of HELLP syndrome, our MG team is well. So now we have, but the mortality is not so high for HELLP syndrome as such. And morbidity is high.
Yes.
So morbidity is high, and we diagnose early and treat early. So deliver, we now get a lot of partial HELLP syndromes, 1 or 2 parameters alone elevated. And also we have atypical pre-eclampsia. Lot of cases, they don't, BP will be normal or just 30 mm more than their basal value. Their basal value may be 80 or 90, it will be only 120 or 30. But she will be presenting with all features. Some edema will be there, or protein will be 1+. But suddenly these patients will get aggravated. So we have to categorize. So many atypical presentation, partial HELLP, as said, HELLP syndrome with severe pre-eclampsia features, other comorbidities. So these all play. So we have to categorize and then if you go.
But most of the time we don't nowadays start doing the routine urine examination for the antenatal mothers, which is missed nowadays. When I was a UG in 1995, we always do the urine proteinuria for all antenatal mothers whenever they come for the diagnosis, checkup. So most of the time we catch from the proteinuria initially and then start looking for the congenital factors, then only we label. But nowadays these two things are missing in all the antenatal checkups, ma'am. So that would have been a great help. So we are the catch up of these patients, even if they are set up in the second trimester when they are going to rise for a high BP variant, which may not be manifest as a BP rise, but they may still have a proteinuria.
Correctly said, madam, because the proteinuria and BP measurement, which is being, the correct measurement is not done.
Yes.
If it is done in the periphery, now it is given all the, how to measure the BP, how to do the proteinuria. So they say that proteinuria, even the dipstick is enough.
Yes, ma'am.
And if it is positive, then you go for the PCR. Albumin creatine ratio or the protein creatine ratio. 24 hours protein not necessary. These two alone will give a very good estimation. And one more thing, elevated bile acids, we have, we should be very cautious. Sudden IUD and stillbirths form.
Ma'am, the problem is many centers are not having to record how to look for the elevated bile acids in the common setup. It's available most of the time in the private setup, and the cost is also a bit higher. It is around 1,000, where many patient is not affordable. This is also many times it is a cost, or we are missing the diagnosis of bile acids. But we go through the literature and ESL guidelines, they say every week we are supposed to do the bile acid level and LFT. But we do only in the second trimester and nearing the term. But as per the ESL guidelines, they say every week we are supposed to do the bile acid levels and LFT, and we should expedite accordingly the UDCA levels to be adjusted. It can rise even, we can rise even up to 600 milligram OD for the patients who is pregnant when nothing will cause an effect of the baby or the morbidity or mortality. But if it is not done, so then the mortality and morbidity will be more. So this also should be taken into account in the near future, because we do only one bile acid level, we record it is high and then we start treatment. But we don't keep on the records and the follow whether it is rising or falling, whether the patient respond to it or not. So when it is taken into account, we can prevent most of the deaths, ma'am.
Thank you, ma'am. Thank you, sir. Thank you for the speakers and chairperson, sir. So move on to the next session.
I welcome everyone to the second session of the day. I would like to acknowledge and welcome our esteemed chairpersons for this session. Dr. Thai Manavan L, Dr. Aravind A, Dr. Shivashankar, Dr. Cherian A, Dr. Joyman JL, Dr. Rajesh. It is my privilege to welcome Dr. Vijay Shankar, Assistant Professor in the Department of Medical Gastroenterology, Madurai Medical College. He will be presenting on the topic indeterminate colitis. Please join me in welcoming Dr. Vijay Shankar sir to the stage.
Good morning to all. At the outset, I would like to thank the organizing committee for giving me the opportunity to present at this prestigious midterm ISG meet. And I will try to go in Korean speed because it will be ideal, not like Vande Bharat from Tenkasi. And the topic given to me is indeterminate colitis. And I will need to approach this topic in the following headings as definition, what is the incidence, what is the natural cause of the disease, and then the diagnosis of IBD remain indeterminate and what are the methods to resolve it. And before going to the indeterminate presentation, we are all familiar with the classical IBD, and as you know, it is a relapsing and remitting disease, and the Crohn's disease and ulcerative colitis are the two main categories, and each have distinctive features. Ulcerative colitis, as we all know, the disease starts in the rectum in a continuous manner, and the distal colon is more severely involved, and it is predominantly a mucosal disease. Whereas Crohn's have a segmental pattern of disease with skip lesions, and it is a transmural disease, so we encounter fistulas, fissures, and sinuses. And histopathologically, the presence of transmural lymphoid aggregates and granulomas are more specific for Crohn's disease. But there is some subset of patients who doesn't fall into these two categories, and their diagnosis remain indeterminate. And coming on to indeterminate colitis, whether the definition it is pathological or clinical entity is still in debate. Ashley Price first coined the term indeterminate colitis in analyzing colonic resection samples of chronic IBD patients. In them, the microscopic and the macroscopic features were not sufficient to clearly classify into ulcerative colitis or Crohn's disease. And when the definition is purely based on pathological upset, we use the term indeterminate colitis. When the clinical, radiological, or the endoscopic evidence is inconclusive to classify, the term IBD unclassified is used. And the diagnosis and the classification of IBD into Crohn's or ulcerative colitis does not rely on a single entity. It requires the correlation of clinical, radiological, pathological, and endoscopic features. Even then, there will be some subset of patients who cannot be classified, and the range is about 9 to 20% in various studies, and about 50 to 58% of the first attack of colitis will be difficult to classify. And why this high disparity in the first episode? Because infective colitis also mimics IBD clinically as well as in endoscopic findings. And the stool culture positivity, which is classical of infective colitis, also can be encountered in 20% of IBD cases. And also the classical histopathological features of IBD like architecture distortion, mucosal atrophy, and panism metaplasia may not be present in the first episode. Hence, when these patients are followed up for 1 year, about 87% of the patients can be classified either indigenously on Crohn's disease on follow-up. And coming on to the natural history of indeterminate colitis, the term colitis in evolution is used because when these patients are followed up, the longest follow-up study is the Mexican study of about 17 years. About 80% of the patients ultimately turned into being classified as ulcerative colitis, and about 1 to 15% are classified as Crohn's disease, and only 20% remain undeterminate due to lack of a definite diagnostic tool. And what are the situations in which the IBD diagnosis is indeterminate? It is the first is the foremost is the permanent colitis, and the second situation is when the pathologist is not clear of which of other domains other than pathology like clinical, radiologic, endoscopic features, and some pathological variants of UC and Crohn's they mimic each other, and other superimposed infection or diseases on top of IBD which alter the disease course. And coming on to the first situation, the permanent colitis, it is common mostly as the first presentation is rare in chronic IBD patients, and most of the pulmonary colitis is due to ulcerative colitis, and these patients will have Crohn's disease-like features, so that the diagnosis is given indeterminate. They will have classical rectal sparring, fissure ulcers, and transmural inflammation. Some proportion of permanent colitis can also be due to Crohn's disease or non-IBD conditions like ischemic or drug-induced colitis or superimposed infections like CMV and Clausen disease. Though the presence of transmural lymphoid aggregates and granulomas can point towards Crohn's disease, but their presence is expected only in less than 30% of the situation. And the second situation is in which the pathologist doesn't have a sound clinical knowledge of the family history, presence or absence of PSC, or the serological status of the patients, or the presence or absence of perennial disease, or the pathologist is not aware of the radiological features like whether it is segmental or diffuse disease, or presence or absence of any fistulas or strictures, and what are the classical endoscopic findings and the distribution disease and the ileal involvement, and also he is not familiar with the previous biopsy reports, he can't clearly classify the IBD patients into a UC or Crohn's disease. And hence, with microscopy analysis, the accuracy is about 64% with Crohn's disease and 74% with ulcerative colitis. Also, about 20% of the patients with IBD will have a normal radiological imaging, but even in the presence of an endoscopically detectable disease, and when the patients with Crohn's disease is limited to the colon, the diagnostic accuracy of radiology is about only 40%. And hence, the radiology cannot aid as a clue to clearly classify the disease in most of the situation. And the next situation is there is disease condition in which UC can mimic Crohn's and Crohn's can mimic UC. And UC can have Crohn's disease-like features and permanent colitis as already discussed. And UC, instead of being a continuous disease, it can have segmental disease pattern. And also, as we all know, dermal ileum is the disease of Crohn's, it's more specific, but ileum can also be involved in UC, which will be dealt later. And usually pediatric patients will have rectal sparring because usually the disease starts in the rectum. And granulomas, which are more specific Crohn's, they can also be encountered in UC due to rupture of the tips or due to infections. And also upper GI involvement can be rarely seen in ulcerative colitis. And also Crohn's, instead of being a transmural disease, it can be a mucosal disease, and also we can encounter isolated rectal or colonic involvement in Crohn's disease. And UC can mimic Crohn's when a segmental pattern is in the following situation, like after medical therapy or after during the quiescent phase of the disease, or in pediatric population, and in patients with periappendiceal or cecal patch, in which the patient with left-sided colitis will have a normal right colon and some patchy inflammation around the appendix and the cecum, giving a segmental appearance of the disease similar to Crohn's. And as all know, ileum is involved as a backwash event in patients with ulcerative colitis due to inflammation-induced incompetency of the ileocecal valve and subsequent reflex of the colonic contents into the terminal ileum causing inflammation. Also, some other situations like after bowel wash, ischemia, bacterial overgrowth, and infection also, the UC patient can have ileal involvement, resulting in Crohn's disease. And the next situation is that the patients with IBD, they have superadded infections like CMV and Clausen disease, or they have developed other diseases like drug-induced or ischemic colitis. They will have the change in the disease behavior pattern due to the severe, both clinically as well as in pathological aspect. And we all know that total proper colectomy and ileal pouch anastomosis is the treatment of choice for ulcerative colitis patients with those permanent UC refractory to medical therapy. These patients tolerate the pouch surgery better, and the pouch failure is less than 10%, but when Crohn's disease patients were subjected for this surgery, they have disease recurrence in the pouch, and the pouch failure ranges from 30 to 60%. And our subset of patients with intermediate colitis fall close to that of ulcerative colitis and far less than the Crohn's disease. And coming on to the various indefinite solutions, while there are any methods to resolve it, so far the currently available is only the serology. The UNCA positivity is expected in 60 to 70% of the cases, and ASCA positivity of ulcerative colitis and ASCA positivity in 60% of Crohn's disease. But their sensitivity is low, and also they are not so specific, and they can't be a positive way at the situation. And hence, indeterminate colitis, whether it is a diagnosis of exclusion or a separate phenotype, is still debatable, and we need more positive markers like more serological markers and genetic markers to solve this issue. And as far as the characteristic features of indeterminate colitis, they are of early age of onset and have extensive disease and more need for immunosuppressive therapy, and they also have a risk for colonic cancer, and they have a positive history and extensivization similar to IBD cases. And coming to the take-home message, this indeterminate colitis is a diagnosed exclusion. As of now, it is yes. Should colectomy be a prerequisite for diagnosis? It's no. Can serological test diagnose or predict the course of indeterminate colitis? Is as of now it is no. And should patients with indeterminate colitis be offered pouch anastomosis? Yes, they can be offered in permanent cases. Does indeterminate colitis remit with medical therapy? And the answer is yes. And also they also have the risk for colonic cancer. And hence, the indeterminate colitis, as of now, it is a disease in disguise. It can change into somewhat pleasant, somewhat pleasant Madhulika to marry Prasan, or can transform into toxic Nandini to kill Aditya Kariwal. Thank you.
Thank you, sir, for the wonderful session. It is with great pleasure that we welcome Dr. Vadivel Kumar, completed MBBS in Madurai Medical College, MD in General Medicine in Coimbatore Medical College, and DM in Medical Gastroenterology in Madras Medical College. He will be presenting on the important topic, flares in inflammatory bowel disease. Please join me in welcoming Dr. Vadivel Kumar, sir, to the stage.
Good morning, everybody. So, as I said, I would like to thank the organizers for giving this opportunity. So, my topic of discussion will be on hybrid flares. So, this is a common scenario, day-to-day scenario, what as a practically gastroenterologist we encounter, and it's very difficult to deal with these kind of cases. So, as you all know, the basic drug therapy is the 5-ASA, and it is selected based on the site of the disease involvement. So, as far as the disease course is concerned, so we all know that there is no medical cure for IBD. It's a lifetime disease. The best way to address diseases is at the early disease stage before development of complications, both in ulcerative colitis as well as in Crohn's. And during this period, so we always tend to encounter a lot of flare-ups in the return of symptoms after having a disease-free or a symptom-free interval. So having periods of remission followed by weeks to longer flares is going to be an indefinite problem to us as well as to the patients. So we all know the treatment goals for this inflammatory bowel disease. So we predominantly focus on inducing remission and maintaining remission. But the most important thing from the physician point of view as well as from the patient's point of view is the restoration of nutrition, maintaining a good quality of life to minimize the disease and treatment-related complications, and appropriate surgical intervention when there is a need. So, a flare is a period of time when symptoms and inflammation from ulcerative colitis or Crohn's disease become reactive. So, this commonly presents with a sudden flare of symptoms like diarrhea, abdominal pain, or blood in stools, and which can be definitely documented as a CDA score of greater than 150 or a Maya score of greater than 2. So, what are the signals that tells us the patient is going to have a flare? Difficulty in sleeping can also signal that an IBD flare is about to happen. This is the most important thing. And we all know that chronic lack of sleep can affect the overall health and worsen the quality of life of the patients. So this is my own experience in my center. So we have predominantly IBD patients with predominantly 51% as females and 43% as male. And the IBD age distribution, they got a dual distribution, 18 to 30 age group and 51 to 60 age group. And you can see the female predominance in this part and the male predominance in this part, older females. So as far as IBD subclass is concerned, so we do see 56% of ulcerative colitis, 33% as Crohn's, and 11% as unclassified. As far as the ulcerative colitis distribution is concerned, it is predominantly seen in the 40 to 60 age group. And you can see that the left-sided colitis is more than that of the pan colitis. And as far as the gender distribution is concerned, So we can see that left side colitis is predominantly seen in both male and female, as well as whereas pancreatitis is predominantly seen in females. Pancreatitis again, 42 to 60 age group is predominant, with female preponderance in this group as such. And left sided colitis again, we have got two well distribution, 18 to 30 and 41 to 50 age group, with female preponderance here. And the flares, predominantly 80% of individuals with ulcerative colitis tend to have flare, whereas 20% of individuals tend to have flare in Crohn's. Again, the flare distribution, predominantly seen in females. And of this 56%, 11% of my ulcerative colitis are on biologicals, whereas 7% of pancreatitis patients are on biologicals, and 4% of ulcerative colitis are on biologicals. Again, predominantly females tend to be on biologicals here, and few patients on small molecules. You can again see that females predominant in this age group of ulcerative colitis, whereas male in the above age group, and immunomodulators in 4% of disease individuals. So, on the workup of flares, so we have seen 2 cases of Clostridium difficile in patients with Crohn's, and intravascular care in case of ulcerative colitis, and 2 cases of reflux zoster in ulcerative colitis on Tofasco, and 2 cases of CME colitis in ulcerative colitis. So, what causes this flare? So, it's basically risk factors for IBD apart from the symptoms. So, as you all know, the common triggers are the drug non-compliance, which is the most important thing, followed by infections, antibiotics, NSAIDs, which we commonly tend to forget. So, these individuals are to be emphasized that they have to avoid NSAIDs. Apart from that, the conventional things like smoking, cigarettes, alcohol, stress, and the most important thing is not to miss the development of dysphagia or malignancy, which can present as a flare. And certain diets like gluten-like or lactase deficiency can also precipitate a flare. And a coexisting IBS at the last. So this is one study which I could find in the net, which was published in 2014, and just shown that NSAID is the most common cause, followed by the drug non-compliance, stress and infections. And again, even if you're going to be very compliant, still you can still have a flare. NSAIDs, how does it cause? It alters the prostaglandin production, and it also increases the leukotriene production and increases the enough kappa B signaling. Antibiotics, this alters the bowel flora, which can be predisposed to flares, but it's often being used in patients with Crohn's disease with strictures, which can benefit the patient. And IBD and lifestyle, so this is a very big topic of research, so it has to be individualized. The proposed mechanisms are possible overreaction of the immune system to the common bacteria derived from the food. So it is important to ask them to keep a diary of their food and make some modifications that may help reduce the severity of symptoms. So this is the common causes of flares among the food, the greasy food, spicy food, whole nuts and seeds, raw fruits and vegetables, some of which milk, cream, citrus fruits, legumes, and a high fiber diet, the red and processed meat, sweets and added sugars. Next comes the most important things, what kind of fats you can take or oil you can take. So we need to choose between the omega-3 and omega-6 fatty acids. So omega-3 is anti-inflammatory, whereas omega-6 is inflammatory. So we need to predominantly start advising our patients to use a diet which is rich in omega-3 fatty acids, walnuts, rapeseeds, and grass-fed meat and dairy, which is an important thing, and oily fish. So what we commonly see in advertisements are all these oils which are rich in omega-6 fatty acids, so which we need to ask the patients to avoid. What is good? The omega-3 rich diet, predominantly canola oil, the soybeans, salmon, spinach, walnut, chia seeds, kidney beans, flax seeds, all these are rich in omega-3. So we need to ask our patients to be taking more of this omega-3 rich diet instead of omega-6. So IBD in dairy. So predominantly it's seen with Crohn's where there's an amount of the small bowel which can cause lactose intolerance because of lactase deficiency. And these individuals need to be supplemented with additional calcium and vitamin D. Gluten, there are no studies, but in some individuals it can cause less bloating, cramps and fatigue. Probiotics, again there are no studies to support this thing. Some individuals might get relief by taking probiotics. IBD in fiber, that's common connection that fruits and vegetables are good for bacteria and help encourage the growth of less inflammatory species. This has to be avoided particularly in patients with structuralizing IBD, whereas a low frequency diet may be helpful in these individuals. IBD in sugars, FODMAP diet, which is very difficult to follow. In general, we can ask these patients to be on a sorbitol-free diet and avoid alcohol and caffeine. When considering the triggering factors, do not remove the food groups without the support from a nutritionist, as this can lead on to nutrition deficiencies. If you remove food, replace it, maintain it so that they can maintain the enjoyment of the food. Often it's not necessary to remove food. Just by changing the type of food, swapping for a similar alternative, changing the texture or altering the component of food with the help of nutrition may benefit these individuals. And the most important thing, tolerance to a food in a flare is different from the tolerance to a food during remission. They may be able to tolerate these kind of foods during the remission but not during a flare. This has to be avoided. IBD and smoking, we all know, it can lead on to more complex disease, penetrating and citrus disease. And stress, we all know it's a pro-inflammatory cytokine. IBD vaccines, this is a new thing. So we can advise all these our patients to be on these vaccines, vaccination schedule, as they are going to be on immune suppressants. And we have to avoid live vaccines. Stay current with your screening and preventive care. Take home message, ensure drug compliance, avoid insects, avoid smoking and alcohol, avoid processed food, avoid preservative containing food, avoid omega-6 fatty acids. In select individuals, ask them to go for a gluten-free diet or lactose-free diet. Probiotics may or may not help. Antibiotics, only definite indication. So we need to emphasize that our patient has to discuss or disclose the presence of IBD to their treating physician. Vaccination in all our individuals without any live vaccines, and relaxation in the form of yoga and physical exercise may benefit our patients to tide over the flare. Thank you.
Thank you, sir, for the wonderful session. Next, it is an honor to welcome Dr. Hariharan M, consultant, gastroenterologist, hepatologist, and interventional endoscopist in Apollo Hospitals. He will be presenting on a critical topic of difficult to treat inflammatory bowel disease (IBD). Please put your hands together and give a warm welcome to Dr. Hariharan, sir.
Thank you very much. The respected chairpersons, my colleagues and dear friends. At the outset, I would like to extend my warm wishes to Dr. Kandasamy and team for organizing this conference, and thank you very much for the invitation. Two things. I've been given a topic, difficult to treat IBD. There are two things. There is a clear difference between difficulty in treating IBD and difficult to treat IBD. The other thing is that you have to understand, you go to an exam knowing a topic very well. Like, if you know something about, you go for an exam thinking they're going to ask a question about cow in the exam. But then in the exam they ask you about a pole. You still don't know anything about the pole. So what you do is you write all about the cow. And then finally say, you take this cow and tie it to that pole. That is exactly what my topic will be today. And, so the agenda would be to introduction, incidence of IBD, pathogenesis, therapeutic strategies, evolution of treatment, treat to target, difficult to treat IBD, finally it comes. Why, definition, and what is not and how to manage. Incidence and prevalence of IBD based on global burden of diseases survey 1999 to 2019 shows a decreasing incidence with increased prevalence, particularly in the West, but and China and USA have the same maximum case growth. Indian case scenario, you can see that it shows 2.7 lakhs against 1.3 lakhs in 1990, which is truly an underestimation. Previously, only two population-based surveys were carried out, one by Costa et al. And other by Sood et al. The prevalence was 44.3 for UC, and the incidence was about 6, which was done by a survey 1 year later. Indians have the highest range of incidence and prevalence in Asia in another study by Ning et al. And the mean annual incidence for Indians for Crohn's was 3.91, and for UC was about 5.4 per 100,000 population. Pathogenesis is clearly unknown, including UC and Crohn's. It's a chronic relapsing inflammation, worldwide problem, and an increasing incidence, particularly in India. Largely unknown, complex interaction, multiple factors, and however, whatever you do, you address only one factor, which is the aberrant immune response, which you continue to tackle and treat. Your therapeutic strategies in IBD basically would be to achieve a symptomatic response and remission, normalization of biochemistry, endoscopic response and remission, followed by mucosal healing. All of you know the current strategy is only treat to target, which is what is advised by IOIBD. You all know what is treat to target. You fix a target, try to keep treating the patient till you achieve the target and then maintain the target. This is the simple algorithm where you got immediate short-term targets, intermediate targets and long-term targets. I don't want to go through this, which most of you would know, and this is a pictorial representation. And the last one, not considered as formal targets, are the histological remission in UC and transmural healing in Crohn's disease, which are likely to be the targets of the future. Why mucosal healing? Mucosal healing is because it prolongs clinical remission, longer time to relapse, and reduction in hospital admission and surgery. In spite of major inventions in drugs, you still have a lot of unmet need in IBD. There is lack of cure, long-term maintenance. Despite biologics and new molecules, maximal clinical remission rates are only 50 to 60%, which is the maximum therapeutic ceiling. Current treatments available, long list starting from sulfasalazine, 5-ASA steroids, immunomodulators, which are actually the standard therapy, and then you've got biologics and small molecules, which are the advanced clinical therapy. The advanced therapy includes mono, combined, dual, and targeted therapy. The newer therapies include dual targeted therapy, which is a combination of two drugs, which may be two molecules of biologics or a biologic with a small molecule. Useful in resistant IBD, particularly in difficult to treat IBD. There is no strong evidence it is effective. In penetrating CD, it is found to be very effective and has the best response. And there is something called bispecific antibodies, which you have to understand. Bispecific antibodies can connect to two different targets on a single antibody, by which you can target the difficult to treat IBDs better. Coming to difficult to treat IBD, not difficulty in treating IBD, it's difficult to treat IBD, which has recently been defined and has been defined only a few months ago. Last September 2023, this was defined following an IOIBD consensus. And I'm going to talk about why we have to define this difficult group of patients and what constitutes a difficult to treat IBD and what is not, and the approach to difficult to treat IBD. This is why did they define this group of IBD is because it is for a group of patients who fail all treatments despite their latest drugs. What is happening is that these patients would have already been exposed to the formal drugs which is already available, and any exposure to a single biologic makes them prone for failure with subsequent biologics. This has been time and again proved in all trials that one failure to one biologic leads them to another failure, and henceforth in all trials they will always be excluded. There is no treatment guidance on these people who have difficult disease. They are difficult for assessment severity. They have multiple interventions and multiple influences, including psychosocial abnormalities. There is an absence of efficacy and safety data in resistant patients. If we can define these patients with a common terminology, you can focus, raise attention, and give special care to these patients, and these patients can be recruited in clinical trials and we can promote research. How did they define it? It was through an IOIBD consensus statements. They took clues from oncology trials. What happened was that oncology patients receive multiple drugs and they are thrown out once they don't respond to treatment. Such patients were taken up for subsequent advanced treatment by combination drugs, which is how they took it up with IBD as well. And from EULAR, EULAR is European Union League Against Rheumatism. They classified difficult to treat rheumatoid arthritis patients. It is another type of immunological disease, and the same clue was taken for IBD as well. They decided on 20 statements under 3 domains, which include treatment domain, disease phenotype domain, and patient domain. It was through a modified Delphi process by voting, where more than 75% voting is taken as positive. 5 were included and 15 statements were excluded. Only these 5 groups fall under the difficult to treat IBD, which include failure of biologics and small molecules with at least 2 different mechanisms of action. Number 2, recurrence of Crohn's after 2 resections. Number 3, chronic antibiotic refractory bronchitis, complex perianal disease, and coexisting psychosocial issues that impair adequate clinical management. What is not is a long list. I cannot go through this list because of for want of time. There are 15 which many people perceive as difficult to treat IBD, but they are difficulties in treating IBD, including upper GI involvement, patient non-adherence therapy, and patient self-perception of a difficult disease. How to improve IBD care and make it more effective? Therapeutic drug monitoring, biomarkers, metabolomics, microbiomes, mutation, and genetics. Personalized IBD care is nothing but predicting the response. The earliest markers would be CRP and FC, which is fecal calprotectin. We got a long range of new intestinal mucosal proteins, genetics, which predict the formation of anti-TNF antibodies, microbiota, which can say somebody is going to have a relapse after infliximab withdrawal, metabolomics like tryptophan and bile acids, which can predict response to biologics, integrins, IL levels, oncostatin, all predict response to IBD. Management essentially is pharmacological. You give advanced treatment including combination therapy, targeting dual pathways, lifestyle management including diet, stress, and smoking cessation. You have to refer them to a specialist who is interested in managing advanced IBD patients. Use of MDT, personalized care, monitor for side effects, psychological impact, research, and updates. So in conclusion, pharmacy of IBD is rapidly evolving. Newer molecules are available at a faster rate and are potent. Oral molecules may replace injectables. IBD care continues to get better. Personalized precision care may become the future. Treatment of difficult to treat IBD care continues to evolve. Trials on the way and no published results yet. As this was just recently defined about 12 months ago, there is only one published paper on the role of the biologics in 4th and 5th line, which I have not even seen the second yet, but they are talking about 4th and 5th line biologics and its persistence, and they found out that risankizumab is the best to persister in 4th and 5th line, and multidisciplinary approach would be the way, including pharmacy, microbiome like FMT, genetic studies, lifestyle, form a part of the care. These are my major references. And thank you for patience. Thank you very much.
Thank you, sir, for your engaging speech. Now I'd like to hand over the session to the chairperson.
Thank you. I think all the 3 speakers stuck to their topics very well. The first topic was indeterminate colitis, and the last word that is underlined is that if you have an indeterminate colitis, treat it as ulcerative. It's not uncommon that you find patients who you think is ulcerative colitis by clinical as well as endoscopic methods. So the biopsy comes as plenty of granulomas. It's not very uncommon, but the treatment still continues, and I think that point was very well stressed. The second speaker talks on flares. He have an excellent account. When flares come, please think of a different disease. Can it be CMP? Can it be something else? Can it be failure? And I think he discussed the differential diagnosis very well. And not to mention Dr. Hariharan tells us about the biological sense, the evolution and the difficulty. First question to start the discussion, Dr. Hariharan. If somebody fails on adalimumab, who's been under and we find that truly somebody who's relapsing, what would be your first step when somebody relapses, has pain? He is on
basically that is one biological failure. I was basically concentrating on this specific group of patients called difficult to treat IBD. I was trying to define because many people, this is a difficulty in treating IBD. This is just a first biological failure. If somebody fails on a biological which is an anti-TNF, first thing is that I will have to find out the reasons for failure. Rather than just simply, there could be so many issues in a biological failure. It is not necessary that the drug would have failed, but either right from, you have to assess the various factors, right from the patient to the drug to the combination and the type of disease. First of all, is the patient taking the drug properly? You have to assess the drug level. You can do therapeutic drug monitoring in such cases. So each failure has to be assessed on its own merit before you say truly that this drug had not worked out. I would have approached by step, right from the patient towards it.
The topic is open for discussion.
How long the biological to be continued for this crystallizing Crohn's disease, which is a very difficult scenario?
No, it is a difficult to treat. It's not difficult to treat IBD. Again, difficulty in treating IBD, but a very difficult crystallizing Crohn's has been classified as difficult to treat IBD. It is as such for life. For life. So that is a difficulty, sir. That is not a difficulty. That's a difficulty, but unfortunately, as of now, there is nothing called a stopping point. But then there are some stopping points. Even in biologics, there is something called a point where you can start withdrawing biologics. So for that, you have specific points. What you should do. Like, particularly if you have for ulcerative colitis, if somebody has achieved histological remission, wait for at least 2 different biopsies to show absolute complete histological remission, where their histology comes back to normal. Then you can even think about withdrawing biologics. Even in such cases, the relapse tends to happen.
Very good talk. Just wanted to ask you a doubt. How do you treat tuberculosis Crohn's overlap? Do you see in your practice does it exist?
The main thing is that the tuberculosis IBD overlap will happen only on 2 occasions. First, when we start treating somebody for an IBD with biologics, despite taking all, I do take a complete clearance from the ID specialist before I start the biologics. Despite that, we do sometimes have a flare-up of TB. When that happens, the first step would be to immediately stop the biologics, because tuberculosis is definitely, if it flares up and becomes totally miliary, it's going to kill the patient. So we wait and then clear the tuberculosis, start the treatment. Once his TB shows him, goes into remission, wait for 8 weeks before we even restart the biologics. That's the only place where the initial phase I do see that there is an overlap of tuberculosis and IBD. But otherwise, when it happens, I don't start them on both when there is a doubt. I always wait, clarify before I go for treatment.
Mohan, just to tell you, 20% of people before they are treated as Crohn's have treatment for tuberculosis. They have had exposure empirically or otherwise.
Just to add to the point, I always feel, it is always better to treat somebody as TB than Crohn's, because one thing is it is safe. If you treat TB as Crohn's and put them on immunosuppression, the patient will get into trouble. But if you treat Crohn's as TB, nothing happens. After all, he will have some difficulty and some symptoms which can easily put up. But the other way around is always difficult. So I always tend to treat them as TB first, even before I can approach the patient.
Absolutely agree. So it's a finite therapy. But then you would call back the patient after 8 to 12 weeks for a repeat colonoscopy, terminal ileoscopy, whatever, repeat biopsy, just see symptomatically how it's improving and histologic.
Certainly, even there are times that, sometimes at the end of 8 weeks or 10 weeks, even the Crohn's patient may temporarily go into remission. We do have difficulties, but it is always best because of its finite therapy and because it is preferable you treat TB first before Crohn's.
Just wanted to highlight one case which we have recently come across. Young female who had symptoms of chronic diarrhea, and then she had undergone a colonoscopy, and then we had only ileocecal valve and terminal ileal involvement. Biopsy came as microgranuloma with mild caseation, but otherwise the colon was normal. The discussion was with the pathologist to see whether it could be a tuberculosis or whether it could be an IPT Crohn's disease. But they said the ASPFP stain is negative, the TB-PCR was negative, so they were not sure. They said they cannot categorically say it was TB. So we put her on treatment for IBD Crohn's disease. She improved greatly, and we called her back, like Dr. Mohan Prasad said, after 12 weeks for another colonoscopy. The ileal ulcer remained. So this time we did a biopsy again, and we still got the microcancer.
And again, we had a discussion with the pathologist saying, we are treated for Crohn's. He's still got the microgranuloma. You say it is TB again. So we need to treat. So they again said the AFB is negative, the PCR is negative, we are not so sure. So we started on ATT and then got it back again. The ulcer disappeared. So I don't know, but then we made a mistake of giving her treatment. We just put her on budesonide and mesalamine, but then we didn't give her too much. But then whether is that an entity called an overlap? I think it is primarily only one disease. We don't know whether it is an overlap, and I don't think we should be talking more on overlap, but probably make a decision to treat whether it's IBD or TB. And this was an example which gave me a lot of lessons. And then now I'm very, very careful in probably discussing with pathologists, taking their opinion, then probably starting them on specific treatment and not combination of TB and IBD. Dr. Ganesan, ma'am, what's your opinion? Thank you, ma'am, on this indeterminate overlap.
I think we have come across these instances on quite a few occasions. There's a recent paper from AIG which has commented.
There was a paper from
AIG
Delhi,
that if from AIG, from Rupa Banerjee's group, that if you treat Crohn's or tuberculosis, 20% can land up with stricture. So be very, very careful when you're treating a person for tuberculosis when you're suspecting Crohn's. So they always say hold on. 20%, and that's a difficult stricture to manage in Crohn's.
But if you don't know and then you put them on ATT, then you're committing them to a 6 months treatment.
Yeah,
not knowing whether
8
it's
weeks.
tuberculosis at all.
8 week we take a call. 8 week we take a call for the colonoscopic evaluation. If it heals, then you just continue with ATT. But I always have a discussion with the ID specialist on these
But
occasions.
Ganesan, in your case, I would have gone for ATT first, not treated as Crohn's. I'm saying that's what I also think that I could have.
No, that's what my call would be is go for ATT first because it's always safer. Safety is with ATT, not with the other.
Because it becomes, we take a stand which is think it's best for the future. Seri and Sai, can you please?
I'm getting behind the podium, so I want to use this mic, sir. So I have 2 points to add. We have always have difficulty in making diagnosis for IBD even after having a confident endoscopic appearance because of the pathologist finding. I have a point that we have to use a large jumbo biopsy forceps when taking biopsy. When you use a regular biopsy forceps, we get the tissue which is not very good to interpret by the pathologist. If you use a large jumbo biopsy forceps, I say the specimen will be very good for the pathologist to interpret. And another point, Vadivel Kumar said about the diet extensively. So the omega-3 fatty acids we discussed extensively. So there is no good source of omega-3 fatty acids in vegetarian side. Because all the vegetarian sources contains only alpha-linolenic acid. So our human body may not be able to convert that into the EDA and DHA. So the only good source for omega-3 is animal source only, which is fish. If a vegetarian is wanting to use the omega-3 fatty acid, that is products available which is taken from sea algae. Okay. And I have one question. So suppose if a case of IBD and also rheumatoid arthritis who is requiring NSAIDs, how do we manage?
You can't manage the patient wisely, there's nothing else. But the best way is to, if you want to avoid NSAIDs, the best way is to keep them on biologics. Keep them on biologics. I think for one of them, I think
Thank you, speakers, and thank you for the chairperson. Moving on to the next session, which is the legendary lecture. So, respected guests, it is my privilege to introduce Dr. V.G. Mohan Prasad, sir, a visionary in the field of gastroenterology and a true leader in public health initiatives. So, coming from a family deeply rooted in service and philanthropy, Dr. Mohan Prasad, sir, has carried forward his legacy with remarkable contributions to medicine. He has founded the VGM Hospital Institute of Gastroenterology, India's first single super specialty gastroenterology hospital to receive the NABH accreditation. So he's also a Guinness World Record holder for hepatitis awareness programs. And with numerous prestigious orations and publications to his credit, Dr. Mohan Prasad sir is a leader whose work is making a global impact. So please join me in welcoming Dr. V.G. Mohan Prasad sir to address the gathering. And I'd also like to invite the chairperson from the dais, Dr. Jagannathan sir, Dr. Loganathan sir, Dr. Prem Kumar sir, and Dr. Bhaktavachalam sir.
First of all, I thank Dr. Nagoswamy for inviting me to join February phase. Because of want of time, I invite Dr. Mohan Prasad to talk about the values lecture. He does not need any introduction. He is well versed in all aspects of gastroenterology. I invite Dr. Mohan Prasad.
Respected chairpersons and my teachers, I deem it a great honor and privilege to be standing before you, and my gratitude to ISG Tamil chapter, Dr. Brahman, Dr. Sandasamy, and the entire team for giving me this opportunity, and also for the wonderful hospitality and the ambience that you have provided here in Kutralam. My first visit to Kutralam, so I'm just really, I was enjoying it. So thank you so much once again. So the topic is legendary talk. I'm not a legend, so I cannot give a legendary talk. So, but I thought I'd speak about legends. That's what I'm going to do today. So, who's a legendary doctor? A doctor who combines skill, character, and the drive to make a lasting difference, balancing technical excellence with genuine humanity, and one whose attributes go beyond clinical skills, involving personality traits, professional commitment, and a lasting impact on the community and the field. So you have to be holistic to be called a legendary doctor. And one such is Dr. B.C. Roy, who was born on the same day and died on the same day, July 1st. That's why we have it as Doctor's Day in India. And he was Mahatma Gandhi's physician. And when Gandhi refused to take pills when he was almost moribund and in deathbed, he refused to take medicines because they were made in England, and nobody could make him, motivate him to swallow the tablets. He was sitting in Naukali, and then it was B.C. Roy who threatened him and said, if you don't swallow the medicine, you will die. You know Gandhi, very adamant. He said, of course, I don't mind dying, said. But Gandhiji, remember, if you die, all the Hindus and Muslims will fight across India. The whole India, millions will die. Do you want that situation? He immediately looked at him and said, drink those tablets, and swallowed. So that sort of a dynamic leader who was Chief Minister of West Bengal, and when he was still a practicing Chief Minister, which is treating the poorest of the poor free of cost every evening. The surgeon and a physician is an FRCP and FRCS man. Amazing personality. He's a legend, and we all emulate all his footsteps. And my humble tribute to all my gurus. And the word guru in Sanskrit comes from two words. Gu is darkness, ru is to drive away. So guru means a person who drives away darkness. And these are all my gurus, Dr. T.K. Ganeshan here. Here this is Dr. T.K. Ganeshan at Coimbatore, who got me love medicine. Can I have some silence at the other end, please? Hello? Just silent, please. Few minutes. It's disturbing my speech. Sorry. So, this is Professor T.K. Ganeshan, this is Professor N. Madana Gopalan, and this is the man who got me love medicine, this is the man who got me love gastroenterology. And this is Professor Madana Gopalan doing the endoscopy. All you juniors will be really thrilled to look at this picture, how difficult it was to do endoscopy. Today you're all looking at endoscopes on 70 mm screens. And this is Professor P. Rajasambandam, who was my head of the department when I was doing my DM in the final phase. And of course, you don't need an introduction to Professor KRP. He's our beacon of light and a leading personality in the field of gastroenterology pan-India, and was established the Tamil Nadu ISG and doing fantastic service. Even after the seniority, is still working towards gastroenterology in Tamil Nadu. And of course, you publish or perish. This is the big lady. And we are finishing, we are still not publishing. I'm trying to motivate my juniors to do that. Professor Rangabashim, and all these are my teachers. Bala was my immediate junior in the field of gastroenterology. When I left, when I was doing my second year, he was the first year PG. But he's my guru and mentor and philosopher. And every lecture that I do, he'll say either thumbs up or down. And he'll have very critical comments. And Dr. Taimanavan is my teacher in MD, and all of them are my teacher. Professor Raghuram. I owe all my gratitude to them. And if you see, this is a picture in Madras Medical College, and I'm just trying to put my face at least to be visible in the photograph. So that is the sort of situation I was in when I was in Madras Medical College GH, when I was doing my DM program. So inspired and transformed, my journey through path-breaking stories and philosophies is what I'm going to take you through. And I'm not going to tell you stories from Jataka tales, but however, I just wanted to show you some attributes of a legendary doctor and some examples of those. Commitment to research, innovation, and visionary leadership. If you want to think of somebody in India, I would think of these two gentlemen. Amazing versatility. So continuing research and also teaching and hand-holding and giving leadership for the whole world. So Professor Nageshwar Reddy with AIG and Professor Shitsari with ILBS. So moving on, what about happiness, contentment, and steady wisdom? Mona Lisa. So always the smile is enchanting. So you have to be, happy in your life, but not because life is full of reasons to smile, but because your smile itself can make others smile. Smile is infectious. So keep on smiling, my friends. You can win the hearts of everyone. So, and the happiness and contentment, a lot of messages came from the Hellenistic philosophy from Zeno and Psyche of Cyprus. This was almost 2,300 years ago. So, and this is a Stoic happiness triangle. So, it has got three, messages here. One, take responsibility of whatever you do. If you are destined to be a DMO, you are destined to be a HOD, whatever, do your fullest. So, live with Arite has gone in the corner. So, Arite is living to your fullest every moment, moment to moment to moment. Give your best, give your fullest. That is living with Arite. And then, of course, do your best, whatever you can, but do not bother about what comes out. Karmaneva adhikaraste ma phaleshu ma karma balahetu bhurmate sangaha astu akarmani, said Krishna to Arjuna. Karmaneva adhikaraste, you have the right to do your duty. Ma phaleshu, not as a fruit. However, because of this, you should not be doing deeds which will yield you fruits. You should not aim at fruits and do duty. That's what it says. So, and then also you should not play inert. So, Sangaha astu akarmani. So, this was given 5,000 years ago. All this Stoic philosophy came 2,300 years back, whereas this was 5,000 years back. You see here the steady wisdom. A person with steady wisdom is called Sthita Prajna. Sthita Prajna has got a stable mind. And what sort of stability? Sukha dukkhe same krutva lava alava jaya ajaya tado yuddhaya yujyasya na evam papam avapsyasi. So, you see, you treat sukha and dukkha, lava, alava, jaya, ajaya, all these equally. Then you don't get the sin in fighting. So that's what Krishna told Arjuna. And he who's one who's got a stability of mind, whether it is success or failure, is called Sthita Prajna. So we all have to learn to live like that. Then, we are leaders. And, it was Bhagavan Ramakrishna Paramahamsa to whom, like KRP sir is very devoted. And he was the one who said, like a child running around a pillar, you hold on to the pillar and run around, he doesn't fall down. So if you have Ishwar Dhyana as the pillar, and if you keep running around, you won't get thrown out, you won't get astray in this materialistic world, said Ramakrishna. So have a stability of mind, have the central Ishwar Dhyana, and then you're fine. And with Ganesha, what do? I'll break 20 coconuts, 30 coconuts if I win this in business or examinations. That's not the right way to address him, my friends. The big head tells you to think big. The broad ears and the moving ears keep telling you, keep on gathering as much info as possible. And the long pointed trunk tells you, find the truth in whatever you see or hear. Ekkurul yar yar vai ketpinum, apkurul veikkurul kanbada arivu said Baluvar. So keep on finding the truth. The narrow pointed eyes tell you that you have to concentrate on whatever you do. And one thing that is invisible in Ganesha's face, what is that? The mouth. If you keep your mouth shut, you are safe most of the time on this planet Earth. If you keep eating, then you put on a paunch like this, like Ganesha, which shows contentment. And if you keep on talking, you get into trouble. So keep your mouth shut as much as possible. And the Lord of Wisdom is called Buddhi, sits over a mouse. An elephant sitting over a mouse, that is absolute nonsense, is it not? The mouse will become chutney if an elephant sits on it. So why is it given here symbolically? Is that the mind is driven by the panchendriyas, it keeps moving like a mouse. You see mouse running in the house, hither and thither, same way the mind runs. So if you keep the wisdom on top of the mind, the wisdom sits on the mind, it can keep stapled. And you can have a straight path. You will be a sthita prajna. You will know the direction which one to take. So next time you see Ganesha, please worship him with all these, request him to give you all these attributes. And of course, empathy and compassion, very important for doctors. One of the best doctors recorded in history is Sir William Osler. And this is a man who said, a good physician treats the disease and a great physician treats the patient who has the disease. He was a man who sat next to a lad with a severe moribund typhoid fever, and the patient almost as a young lad in deathbed, and the family was crying. He just sat with them every day with the boy, holding his hand and just encouraging him. And after 2 weeks or 4 weeks, he became all right and walked out. So this was recorded in the history. And of course, Vallalar is from Tamil Nadu, who said he started withering whenever he saw plants wither. That is a sort of empathy. And this is a question which, when I entered the Department of Gastroenterology, Professor Madana Gopalan asked me this question. What is the difference between sympathy and empathy? I was just trying to give some, whatever answers I knew. As usual, he said, get out, go to the library, refer and come back. So I went to the library, Oxford Dictionary, I went to so many dictionaries, I referred and came back and said, sir, sympathy is when you feel sorry for someone, empathy is when you feel pain. So a good doctor feels the pain when the patient is in pain. So that is the greatest quality that you should develop as a doctor. A legendary doctor would have that. And persistence and perseverance is of paramount importance. 10,000 times it was Thomas Alva Edison tried to find a bulb, 10,000 failures, and he finally found the bulb. And you know what he said? I've not failed. I've just found 10,000 ways that don't work. What sort of approach? And his persistence and ability, was really great. And it's very funny that when he was in class 8, his science teacher said, Tom, you're a stupid guy. You should go for some candle making. You're not fit for science. That's what his science teacher said. And if you had only believed, we would not have had the 1,084 inventions with US patents. Thomas Alva Edison. Unimaginable. What sort of persistence, perseverance, unimaginable. So do not brood over past mistakes. And Shivananda said, do not brood over your past mistakes and failures, as this only will fill your mind with grief, regret, and depression, and do not repeat them in future. So these are all lessons to learn from, but not to brood over and keep getting depressed all the time. Just forget about the past. This second is the Saswatam, that is a gospel truth. And the next second is a question mark because we don't know we're going to be alive. So you saw Kalam just getting onto the podium and falling dead. So this is that. So he's a man who said, serve, love, give, be good, do good, purity, meditate, and ritual. I mean, what is that? Realize the ultimatum. And do not cry over spilled soup. Whatever is past is past. A Chinese farmer was walking with a soup ball on a stick as they carry, and then he tripped, and then the soup ball fell down and broke, and there was a splash, and then he kept walking, he never turned back. Then a young lad who was in the farm, came running. Hey, old man, stop. Didn't you see that the soup ball fell and broke? He said, yes, of course, I know, the weight is gone, I could hear the cracking sound, and the soup spilling over my legs. But you didn't stop to see back. So why should I see back? It look back, it's gone. So I don't bother about what is spilled soup. So Thomas Edison's major disaster, where 10 of the buildings burned down by fire in 1914. And then, his son was crying. You know what, Edison said? It's all right. We've just gotten rid of a lot of rubbish. He also said, go and get your mom and her friends. They will never see a fire like this again, said Edison. What sort of, perseverance and what sort of mindset you have had? He just lost $1 million, close to $1 million in that time. And then Henry Ford helped him with money. And then within 4 years, they made $10 million. See that? That's like the great fall of the Niagara, whatever big fall, the river goes unhampered, uninterrupted. Same way, everything is possible, my friends. Only if you can overcome challenges and problems, setbacks. All power is within you. You can do anything and everything, said Swamiji. And impossible is not a fact, it's an opinion. Nothing is impossible. Even the word impossible says, I am possible. And of course, what matters is the attitude of the mind. And I had a challenge when Abdul Kalam, as the President of India, agreed to come to our Karur Vaisya Bank, where I was a director for the 90th. And then, my MD called me 5 days prior and said, Dr. Prasad, I'm very happy that Kalam is coming. I said, wow. Then he said, you're going to felicitate him on behalf of the entire board and the bank. So you're the only guy felicitating. I said, wow. Then he said, how much time will you give me? I asked. He said, 2 minutes. 2 minutes, how to felicitate this man on the stage. So I just immediately sat up, pumped in some adrenaline, and prayed to Almighty. He said, God, please help me. I don't know how to do this. Then, I got a spark. He said, why don't you write a poem? And I wrote this poem for which he loved me. And it's there in Abdul Kalam Museum in Delhi, in the Delhi Museum, it is there. And I wrote it like this: the Kalan Karaitira, the Kalam, Kalan Tanda Vinveri Palan Me, Inga Kanavugal, Nanavaka Vanda Vidivelli, Yalan Portu, Gandhi, and Vadi Nindru, Mahitavaram, Mainbada, Ayara, the Urettavanni, Master Punai, Maniai, Manikamai, Asiri, Permis Ertavanni. தேசங்கள் பலவும் மதித்து போட்டிட நேசத்திற்குரிய குடியரசு தலைவனானாய் நீ உறங்கும் போது வருவதல்ல கனவு மாந்தரை உறங்க விடாமல் செய்வதே கனவு என்றாய் நீ பெறற்கரிய பேர்கள் கனவு காண்பதால் மட்டுமே பெற முடியும் என்று உறுதியாய் உரைத்தாய் நீ முயற்சி திருவினை ஆக்கும் இன்மை புகுத்தும் என முயல் ஆமையிடம் தோற்றது முயலாமையால் என்றாய் நீ நிறுவனங்களுக்கு இலக்குகள் உண்டு ஆனால் நாடுகளுக்குமா இலக்கு விந்தை மனிதன் நீ 2020 என்ற இலக்கை இந்தியாவுக்கு அமைத்து வெற்றி பாதை அமைத்தவன் நீ 100 கோடி இந்தியர்கள் ஒரு சேர நேசிக்கும் ஒரே புனிதன் நீ இளைஞர்களின் இதயம் நீ உன் மலர் பாதம் தொட்டு இன்றே வணங்குவேன் இன்னொரு வாய்ப்புக்கு யுகங்களில் துணையாகும். This is what I wrote and it just literally melted. And this I wrote in 1 hour. You won't believe me. நான் ஜெனரலா போயமெல்லாம் அதிகமாக எழுத மாட்டேன். ஏதோ ரூம் போட்டு உட்கார்ந்தெல்லாம் திங்க் பண்ண முடியாது. This was a situation I couldn't handle, and I could do it. I left the podium in 1 minute 45 seconds today, and that is possible if you think it is possible. If you say, oh no, how can I do it? I won't do it. Then nothing is possible. So my friends, it's the attitude that determines the altitude, and have confidence in confidence, like in Sound of Music. So, and prevent anger, or else get married. So that is the best thing to do. If you can't prevent anger, get married, I will take it out. So anger prevention, one of the living examples, Mahatma, how he could win for this nation, not out of anger, but out of peace and compassion and love. And Osho teaches us so beautifully in his story, like how to prevent anger. He says, a human being is like a matchstick. Matchstick has got a head and a body. Human being has got a head and body. Both are similar, but matchstick you just rub against any surface, it just flares up. And one small fire can engulf a forest. No, Agni Kunjan Kandena, Angor, Katile, Gundire, Vete, Vindu, Tarindu, Kadatar, Viratil, Kunjendru, Mupendu, Mundo, Tatarigida, Tikko, Separ. One small fire can completely, one small flame can engulf a forest. So, Osho says, this is the purest energy that comes from the pit of your stomach when you're angry, as it comes up to your forehead. Stop it there, transform it. Like electricity is transformed into wind energy is transformed into electricity. You can always transform anger into forgiveness, love, and then, whole thing eases out. So, remember to pay back to humanity at large. For example, one shirt. Have you ever thought of how did you get this shirt? They're very interesting when I was thinking. So, you need to buy a piece of land, and the land should be plowed, should be fenced, and then water, irrigation. You should get one of the best cotton seeds, sow it, fertilize, insecticides, harvest, gin it, and then make it yarn, and then weave it into your fabric, and then you dye it, and then fabric is, designed, tailored, cut, buttons, and stiffeners, packed, distributed, retail, and then you should have money to buy it. Even for one shirt, probably 1,000 people have worked. So, in this planet Earth, what have you done to thank the humanity at large? Please remember, nothing is gotten free here. It's because of hard work. And thinking outside the box is something which is very interesting. Like, always think outside the box. So, Thomas Edison, Isaac Newton, Walt Disney, Albert Einstein, Steve Jobs, Marie Curie, Leonardo da Vinci, all of them were great thinkers. Da Vinci thought, when I was looking for the spirus enteroscopy, to the first man who had drawn the airscoop, this picture I have. So, Leonardo da Vinci, of a helicopter picture. Unimaginable. What sort of thinkers they were? They were thinking outside the box. Always keep thinking outside the box in your own career. Can I do something better? If Crohn's, Hari gave a difficult to manage IBD. Now, this is a difficult topic to talk. So, but any difficulty, please think if you can just do something better. So, to overcome the problem or lacuna, Jeff Bezos working at McDonald's, he was the one who made Amazon, and Elon Musk made the Tesla. He used to sell, video games at the age of 12. A lot of people, Michael Dell was a dishwasher. All these people came up. And I had so many firsts in my career because I wanted to do something better, something outside the box. That is how, all these that I did. And the blood bank that I started in Udumalpet has completed. It's a charitable blood bank, Indian Medical Association, Rotary, the first of its kind in the state to combine both. And it's doing so well. And when I was looking at, large bleeding areas, and we had no cooks, the chemo spray had not come into even today it's not available in India. So this was the first patient that I had, was an IT professional, and who had a large ulcers like this, following Stevens-Johnson syndrome. The mucosa was gone, submucosa was gone. What you're seeing is circular muscle fibers. Multiple such ulcers all through the esophagus. Guy who was 65 kilos, when he came to me, was 40 kilos. He said, fell at my feet and said, I'm dying, help me. So he was in Chennai, he was treated in various hospitals in Chennai and came here. I tried PPIs, prokinetics and whatever, like supralphate, nothing worked. Then finally I said, I have an investigational product, but you'll be the first patient in the world. So I said, I don't mind. So I just sprayed collagen. This is on day 4, this on day 10. Complete disappearance of ulcers. He just cried his way through when he became all right. He could swallow his own saliva. my friends. This was my first trial that I did, and now, like 7 years back, I applied for the patent and now got my patent just a few months back for endoscopic spraying of collagen, the first time in the world. So for this, I got my FRCP from Royal College of Edinburgh. They announced in the ceremony that this was given because of this innovation that I could make. So, we kept, when there is a lacuna in your fields, keep thinking, can I do something better? Can I devise something or find something better? Just explore. I'm sure you'll find ways. So, notes, procedures were done in General Hospital with Dr. Panivelu and Khan is here. So we used to, work together. Rajan and myself did all the notes cases in animals and human beings. And this, the first report in the world has my name there, so in the team. So, and of course, I could be the chief editor of 2 books. One already has reached you. The other book, which is coming here, I should thank Dr. Vamshi Murthy, our young budding Andhra hero gastroenterologist who spent sleepless nights to get this book in place. So this book is being distributed now by Alembic to all of you. So it's a pocket book. It has come out so beautifully. I'm sure you'll enjoy it. Teaching is different from mentorship. Teaching is saying, hey, you guys, you go and do the endoscopy. You have to go this way, open the mouth, get in this way, that way, and just explain and then make him do. But mentorship is standing next to the guy and making, correcting his body language. Endoscopy. So endoscopy is very, very important, even all therapeutic endoscopic procedures. There should be somebody to mentor, and my appeal to all you professors is to mentor your trainees and do not just teach, because that's not adequate. So a lot of training programs we've been doing for several years, and of course I could get 2 Guinness World Records, one in 2012 with 3,500 children and adults. And again, I broke my own record in 2013 with 13,522 children, and each one teach them on World Hepatitis Day for the hepatitis awareness, something phenomenal. And what this, I think, my purpose of being born in this country was achieved by this, because when I had to vaccinate 100,000 children in 12 revenue districts, under Rotary District 3200 as a deputy governor. The cost of the pediatric dose of vaccine was 350 rupees Shanta Biotechnic and 750 GlaxoSmithKline. So I couldn't afford it. So I called Varaprasad Reddy, who was the chairman of Shanta Biotechnic and who was my friend. So I just called him, and over a phone call I asked him, can you reduce the price of the vaccine? He said, of course, yes. Said, what price do you want Mohan Prasad for? Said, I want 300,000 doses, but I wanted, don't hesitate, please tell me. Said, 35 rupees? 350 rupees, I asked for 35 rupees. And he said, well, Dr. Prasad, without any hesitation, even for 1 second, he said, we'll take it. He said, I will, not 35, I'll give it at 40, which includes 8 rupees central sales tax, 2 rupees for the syringe, so 30 rupees I'll give you. So 40 rupees, 30 rupees, he brought down the 350 to 30 rupees just over a phone call. And then all the companies in India had to reduce the price because Shanta Biotechnic reduced the price. No one knows about this. Just a phone call between 2 of us. I was feeling very shy to ask somebody to reduce it by less than 10 times. So, but we did it. And then, I got the state of honor about 2 years back, or last year, Rotary gave me this. So, arise, awake, and stop not until the goal is reached. Goal setting is important. So, this is what Uddishkantu Jagrada Prapyavana Nivodha Yamato Nashiketa. Same thing Vivekananda repeated and said, when you're setting goals, set goals which are unachievable goals. And still you will not, try to jump to grab a few stars, you at least will not grab mud. And people used to say, don't be a dreamer, don't build castles in thin air. You can build castles in thin air, said Kalam. Dream, you have to dream before your dreams can become true. And he said, dream is not one thing that you see in sleep, but something that doesn't allow you to sleep. And dreams transform into thoughts and thoughts result in action. You can build castles in thin air, but remember to put a foundation under it. And I could achieve in a small way 100-bedded hospital at Coimbatore, but with all the facilities that US has, we also have. We are not inferior on many institutions, not only mine. So observe integrity and ethics of the highest order. You know what I do? I teach my colleagues. You know what I tell my colleagues? If it is, when you are treating a patient, if it is your own kith and kin, would you have written this test? Would you have done that procedure? The answer is yes, please do it, otherwise do not do it. So if the answer is yes, we are on the right track. And at PGM, I keep on infusing this concept to all my colleagues, surgical team, medical team, everybody, all the DMOs. Do not get bogged down by failures. I'll finish in 2 minutes. So Lincoln's road to success, you see, he had 13 failures over 30 years, 13 failures, not even one success, my friends. Never lost his mind. And finally, he became the most appreciated presidents in the history of the world. So Jack Ma, 10 times he was rejected in Harvard University. It's ordinary college he learned, and he applied for 30 times jobs, rejected, and now he has Alibaba.com. So, and sorry. The stream of life is very important, my friends. Like Kaveri has got origin from a small pond and then becomes a mighty Krishna Raja Sagara in Mysore. So the river can never be stopped. Even when the reservoir becomes full, if you don't open the sluices, it will break and go. So river's mission is to reach the ocean. Your mission is to reach God. So keep on marching. And this is a very rare picture of Albert Einstein with Rabindranath Tagore. Tagore gave beautiful message on live like a river. Please, you should all read it. Marching down the winning path. This is 2008 to 23, 15 years. Tesla overtook all the car automobile manufacturers. Even Toyota just overtook and shot up just because of innovation. And how to be a winner, my last 2 slides. Be a good finder, make it a habit of doing it now, develop an attitude of gratitude, get into a continuous education program, build a positive self-esteem, stay from negative influences, learn to like things that need to be done. Whatever you need to do, please stop liking them. And start your day with a positive. Winners don't do different things, my friends. They do things differently. And this is the last slide. The 26 alphabets in English teach us always be cool, don't have ego with friends or family, give up hurting individuals, just keep loving mankind, never omit prayers, and quietly remember God. Speak truth, use valid words, express your zeal. And that is the end of my talk. I don't know what I did, but my gratitude.
Thank you, sir. You're such an inspiration to all of us.
We joined the entire audience here. It's a great, amazing talk. I have always been seeing you since you became a gastroenterologist. And I think we have been watching you for a period of time. And you ever smiling, you ever enthusiastic, you ever charming, you ever friendly person. And today it was a mix of everything. What a person should live, what a person should have, and how to get the mind on. That was an excellent combination of mind, religion, beliefs, intelligence, perseverance, growth. Excellence, we appreciate. And one word from Dr. K.
One word is really a legendary talk. I don't think anything more than that. I would probably request you all to a standing ovation to run more for
I'd like to ask HOD sir, Dr. Kandasamy sir to felicitate Dr. Vijay sir. Before moving on to the next session, we have the results for the poster and the quiz competition. So I'd like to ask Dr. Loganathan sir to give away the prize for the poster. First prize goes to Vijaya from Thuthukudi Medical College. Second prize goes to Bhavishya Sundar from Meenakshi Medical College. To give away the third prize. Number 3 goes to Sony Thomas from Coimbatore Medical College.
Sir, friend of the channel. Give her a map. All the best. Okay, thank you.
For this quiz, I would like to ask Dr. Bhanumas sir to give away the prize. First prize goes to the team from Mohammed Shahnaz from Apollo and Vyasa S from ADHD. Sachin James and Jason James from KFC.
Sir, ada yang berapa? Sir, one more.
That is from Government Medical Hospital attached to Kirkuk Medical College. So I think that's a wonderful job that they've done. Heartiest congratulations.
Dr. Prem Kumar sir to give away the second prize. Second prize, Mohammed Shahnaz from Apollo and Vyasa S from KFC.
Sir, கொஞ்சம்
I'd like to follow up on Dr. K.R. Palanisamin sir to give away the third prize. Third prize goes to Arif Aslam and Nishal Modak from KFC.
சார் இங்கே பாருங்க லைவ் போட போகிறாங்க உள்ள சரி ஓடிட்டு இருக்கு அதான் சரி 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 அதான் வீடியோ கமெண்டாதீங்க அப்படிங்க சரி சரி வீடியோ எல்லா இடத்துல போடுறோம்
We now go on to the next session.
Shabir Ali, Chief Coordinator and Senior Consultant at KIMS Health, Trivandrum, specializing in hepatobiliary, pancreatic and liver transplant surgery. The session will be chaired by Dr. Barnabas Durelal sir, Dr. Joy Varghese sir, Dr. Venkateswaran, Dr. Brahmanayakam sir. I repeat, the session will be chaired by Dr. Barnabas Durelal sir, Dr. Joy Varghese sir, Dr. Venkateswaran sir, Dr. Brahmanayakam sir.
Good morning to respected chairpersons, respected senior faculty and colleagues. First of all, I thank the organizers, Tirunelveli chapter organizers for giving me this opportunity and inviting us to this wonderful meeting. The topic given to me is to discuss on the role of transplant in acute liver failure, which, as we all know, it's a very dynamic condition, and the role of transplant is a bit recent one, and that the guidelines and the recommendations are always changing, and it has evolved over the last few years. So going to my topic, I will discuss shortly or discuss some salient points on the definitions and grading, which I think it's not my role to discuss these things to you, because you are more experts than me in these areas. Then I will go to why should we consider transplant in these sick patients, and then whom to be transplanted and whom we should not transplant, and I will discuss some of the special situations like alcohol dependence, and then I will touch upon some of the points in how to optimize these patients in getting a good short-term outcomes as well as a good long-term outcome. Going to this topic per se, acute or chronic liver failure is first described in 1995, but the concepts and the dynamics of the disease all have evolved over the last 10-15 years, and it has changed a lot in the last few years. It is basically two insults. One is there is an ongoing chronic liver insult. Along with that, we have got an acute insult, and it mimics ALF, but there are certain basic differences from the acute liver failure scenario. It has got a high short-term mortality than decompensated cirrhosis, as we all know. But indeed, I think in the current era, it has got even worse outcome than acute liver failure. Because of the medical therapy, when acute liver failure has shown some improvement, this condition is now having even worse outcomes than acute liver failure. So going into the definitions, I think these are often discussed in gastro forums, that variations in difference from the Asia Pacific versus the European consortium. Like they define ACLF, basically the definition defining ACLF based on whether you use liver parameters or non-hepatic organ failure for defining the condition and grading the condition and predicting the prognosis. All these differences are there, but basically I think they are all looking at same disease in a different angle. And in our common purpose, we usually use the EASL CLIF grading. That gives us a more, we felt that it is more easy to grade patients and prognosticate based on this grade. Going into the triggers, as we all know, this is from the Canonic study, which has shown the trigger as bacterial infection as one of the common trigger for pushing a patient from chronic liver disease stage into the acute decompensation or acute or chronic liver failure. Alcohol comes second, and then a vast majority of patients, even the trigger is not identified. It's basically, you can see in the graph, these patients are basically even in a better stage than a chronic liver disease and suddenly getting some trigger and going down into that difficult or a bad stage, and then some of them come back, and if not given the proper care or the standard care, or even with care, some of them goes down into a futility of care and mortality. So this is again regarding the grading of EASL CLIF criteria. It is based on the number of organ failures involved, and the grade 1 involves either a single organ failure, that is basically a kidney failure, and grade 2 you have got 2 organ failure in simple terms, and grade 3 you have 3 or more organ failures in grade 3A. 3 or more organ failures. The advantage of this is with this grading you have got a very good correlation with the survival with the natural history. That is, grade 1 has got a very low 28 mortality, that is around 4 to 6%. Whereas in grade 3 you can see it is reaching up to reaching up to 70 to 90%. So this grading will give us an idea about where this patient is going. And this is again from the Apacer group ARC score, which has shown one of the best correlation with prognosis. As I have mentioned, this Apacer group, they always graded the disease based on hepatic parameters. Unlike in the Eclipse COFA score, if you see the R score, every increase in the score, the likelihood of mortality increased by 66%. And it has got a very good predictive value in a 90-day mortality. So from all this, it is very clear that this disease has got, especially grade 2 and grade 3 ACLF has got a very high mortality with the natural history, and we need something beyond a good supportive care in these patients. But the main concern when we think about transplant in these patients there were 2-3 important concerns. One concern was, is there a chance of reversibility in this patient, especially in a low-grade ACLF, some of them can come back to a normal life, normalcy at least to their premorbid stage if the inciting event is removed. Similar way in an alcohol, at least 20-30% patients have alcohol as an inciting event, and these patients there is a big concern of ethical concerns of recidivism coming back to alcohol and damaging even the new liver. And in the third group of patients where they are too sick, and whether the transplant is going to help them, are they really fit for transplant? So all these concerns were there when we consider transplant. So looking to it, we have got now, I think over the last 10 years, we have got good evidence to say that transplant can really save these patients from a very high mortality stage. This is again from the Canonic study, which has got a good number of patients prospectively observed. The 28-day mortality, transplant-free mortality in ACLF grade 1 was 6 to 18%. Grade 2 and 3 was 42 to 92%. And the predictors of severity was, one was Eclipse score C, and total bilirubin more than 12 was one of the predictors of severe grade. And LT in ACLF 2 and 3, drastic survival advantage was there. That was from 95% versus 23% at 28 days, and 90% versus 12% at 90 days. So from this study, it was clear that transplant can really save these patients from mortality. This is again one recent evidence. If you see, this was actually addressing the grade 3 patients. The sicker patients were whether we can, those who are having more organ failures, whether transplant is really going to help them. This was done as a prospective study in King's College. They wanted to see whether these patients can be given a priority in waiting list. So this was 52 patients with ACLF grade 3, median age was 46, 62% required mechanical ventilation at the time of grading, 85% required vasoplan, was 84% versus 8% for matched non-transplant critically ill patients. 4 other studies also confirmed this advantage for transplant. So it's from the current evidence, it is clear that transplant can really save these patients. But the biggest question in these patients is unlike ALF, where within few days you will know the dynamics and you may be able to take a decision on transplant. These patients are coming in and the condition is so dynamic. When to transplant these patients? Should we consider them early, or should we wait for the organ failures to recover? Or then the concern of whether they will go into a sepsis and multi-organ failure where the transplant will become fatal. So the biggest concern in these patients is when to transplant them. So there are, we have some data even from the Canonic study, and another thing, this dynamicity is well established. Like in 3 to 7 days, most patients establish their actual grade. And there is enough evidence that if you wait for the organ failures to to improve with the initial supportive care, there is an improvement in the transplant survival. At the same time, if you wait too long, if they go into further organ failures or into that sepsis phase, the outcomes are bad. So in general, now the concept is you should take a decision. We should have the transplant upfront in the plan. That is, any patient who is a potential candidate for transplant should be viewed, should have a discussion on transplant, and within 3 to 7 days we should take a decision whether to go for transplant. Those who are stabilizing with the initial supportive care should go for transplant. Those who are deteriorating into a futility criteria, we should exclude transplant. So this was again from the Canonic study to show the dynamicity. within 3 to 7 days, most patients will establish their grade of ACLF. And we can take a decision, and we can upfront ineligible. Some patients will be like active alcoholism, uncontrolled sepsis at presentation itself. They are ineligible for transplant. But within 5 to 7 days, you have to find out whether they are going on mechanical ventilation or increase in number of organ failures. You have to wait in those patients. Otherwise, you can take a decision within 5 to 7 days. How to decide on transplant? In short, like a close follow-up is needed for decision making. Worsening organ failure, high anatropes, and worsening sepsis, we should always watch for. We should not jump into transplant. Then we need good markers and scoring systems. We can use all the available scoring system, but more innovations are required in this area. And AFE is a marker of regeneration which can help us whether the liver is coming back or not. Then some scoring systems like transplant associated. There are many scoring systems for identifying the patient's mortality after transplant now. We have to use some scoring systems, and we have to take an individual based decision. This is again one concern which I have discussed, like severe alcoholic hepatitis. Like 20 to 30% of patients coming with ACLF are having active alcoholism. It's a big concern in them. We have two concerns in them. Some of them have got a high potential to recover if you stop alcohol, and at the same time, if you go into transplant, there is a high chance for recidivism as well. So these two has to be very carefully balanced. Then you have to see the chances of recovery without transplant as well, and you have to have a very good psychosocial assessment to decide whether they are going back. They have a chance for going back to alcohol. This is again one study on recidivism. It is like 8 to 33% reported recidivism in alcoholic hepatitis transplants. So we have to look at some scoring systems for these recidivism rates. And again, you have to analyze each patient, see their social support, family support, and his previous behavior. Because they are sick patients, it will be difficult to assess them at that time whether they have got this risk. So we have to use some of the standard scoring systems like ARI, alcohol relapse risk, or many risk assessment tools are available. We have to use them. We have to analyze this patient well to decide on transplant. Then the biggest question, as I have mentioned, whom should not be transplanted? There are various studies have shown different parameters, but I think in short, we have to look at them like that 1 year post-transplant survival, some of the predictors. If it is less than 50%, you should not consider them for transplant. And again, some of the strongest predictors is like, as I have mentioned, like more than 7 days ventilator dependence, development of ARDS, or lung is worse. Lung is one important organ. If it is worsening, like PO2 FiO2 ratio less than 150, we should not consider them for transplant. Then like definitely like MDR organisms in blood which are not getting controlled, or like active fungal sepsis. These are all absolute contraindications. But there are many other predictors which have come up from different studies. So these criteria, these are some consensus statements on whom should not be transplanted. Like looking at a severely frail patient, frailty score more than 7, persistent SIRs and features of sepsis, or as I have mentioned, worsening lung, or worsening of clinical cause, like more and more organ failures are happening. These patients, you should not go into transplant. Just wait for them to improve, or if they are deteriorating, just leave them for the futility of care. This is again another important area. If you have decided for transplant, you need to have an extreme care. You need to address their sepsis. You need to manage the organ failures well. They need a good critical care. So optimize their organ failures, control the sepsis well. Then only you will be able to achieve it. So they need a good hepatic liver critical care support to get a good outcome in these patients. This is again another important area, like role of plex. We are nowadays discussing a lot about role of plex in ALF and ACLF. But looking at the evidence, I think we have got some good quality evidence now coming up for acute liver failure and hyperacute liver failure. But its evidence in ACLF is still lacking. In short, it is a challenging scenario with high mortality. A close monitoring and quick decision making is needed. Evolving these management protocols are still evolving, and we need to select each patient to get a good early outcomes as well as a good late outcomes like alcohol dependence and all. Patient selection is utmost important in these patients to avoid a futile transplant. Thank you.
Thank you, sir, for an enlightening session. We now welcome Dr. Shiraz Ahmed Rathar, consultant and head of multivisual transplant at Kim's Health, specializing in hepatobiliary and pancreatic and liver transplant surgery and gastrointestinal surgery. Dr. Shiraz will be presenting on small bowel transplant indications, outcomes and scenario in India.
Good morning, chairpersons. At the outset, I would like to thank the organizing committee for this opportunity. And this is the best forum to talk about the small bowel transplant, because gastroenterology is all about food, isn't it? The scope of discussion will be, I briefly introduce the topic, indications, some patient stories, and the challenges we face in India. All deaths are hateful, but the most pitiable death of all is to starve. The small bowel transplant is a big undertaking, is a formidable operation, and needs a good multidisciplinary support. You know, the nursing, dietitian, immunologist, gastroenterologist, radiologist. I put the surgeon at the tail of the list because the very simple thing is to do an operation on these patients. And the strength of the team will be determined by the weakest person in your chain. And if one of them is not committed, or not enthusiastic to build up this program in India, you have a bad outcome. Basically, intestinal transplant is not the only hope or the only end of this entity. The intestinal failure is an inability to absorb the nutrition, maintain a positive fluid and electrolyte balance. And it can be temporary, permanent, irreversible. Different grades are there, whether they need to be given TPN or they need to go for a transplant. So intestinal transplant is a part of the management of these patients. It's basically an intestinal rehabilitation program. Various indications in adults and children are a bit different. Basically, the most common is a short gut syndrome where you lose a massive portion of a bowel. Ischemia in adults is the most common cause. Crohn's disease, valvular trauma. Tumors like desmoid and pseudomyxoma peritoneum are the two where small bowel transplant has been done and considered on 13% of patients. The absolute contraindications are a metastatic malignant disease, a systemic disease with a poor prognosis. A patient who is very unwell, is not able to move around a bed, is not probably a good candidate for a kidney transplant, not even think about a small bowel transplant. There are some relative contraindications, like age is basically about 60 in some centers, but it is flexible. It all depends upon the performance status. I'll just mention a story. As I said, it's not about transplant, it is rehabilitating these patients and optimizing their gut length. A 12-year child who just was a very happy-going girl in a school came with an abdominal pain and was diagnosed to have SMA thrombosis. She was referred to our department in 2021. We ended up with a massive bowel resection, just a 25 centimeter of jejunum and 5 centimeter of terminal ileum left alone. So she was optimized, her treatment, she was sent home on a home TPN with an end jejunostomy. Obviously, it was difficult for the family to manage 3 to 4 liters of fluid coming in the bag. So after a month, we took a decision to take her back and reconstruct the bowel with a terminal ileum. This patient was managed in collaboration with the Pittsburgh Small Bowel Transplant Unit for Children, and she gradually improved. 3 years down the line, she is 15 years old now. Her weight gained from 32 to 37, and she is gaining height. She's on a parental supplementation of micronutrients at 6 to 3 months interval. So happy ending, but she is not out of her dart. Another young female, 45 years from Tamil Nadu, came for a picnic to Kerala. Husband drove the car in the early morning hours at 5 a.m. to reach to the destination early. He met an accident, massive bowel mesenteric trauma with a pancreatic head transection. She was taken for laparotomy. Unfortunately, we had only 4-5 centimeters of jejunum, which was not able to be put out into the skin of the stoma. So tube jejunostomy, TPN, multiple laparotomies, multiple fungemias in the hospital. She was never able to go home more than 2-3 days. Ultimately, in 2 months, family got bankrupt and she succumbed to the injuries. We never got we never got a window for transplanting her. So intestinal failure, those patients can be on a TPN-free diet for 30% patients. In some of the patients we can reduce the TPN in 50%, but they need supplementation, and some are lifelong TPN based. So how much bowel is required? Multiple studies say 100 to 200 centimeter. It depends upon how much bowel is left behind and how much bowel was removed. And the type of bowel, whether it's jejunum, colon, ileocecal valve, all determines the length of the bowel and whether the patient will be lifelong TPN dependent or partially dependent, or will they need a transplant. So some of these patients, they develop an intestinal failure associated liver disease, which then again becomes an indication for an intestinal transplant or a multi-intestinal transplant for these patients. So a third patient from Tuticorin from Tamil Nadu, 49-year-old, doing his routine work, had a massive bowel ischemia, and he was diagnosed with SMA thrombosis somewhere in December. Multiple TPN-induced liver injuries and multiple laparotomies, multiple bacterial sepsis and fungemias in 6 months. Obviously, family ran out of money, sold all their properties, whatever they had. This was a jejunum which was brought out as a stoma, and these were the liver functions on his TPN. The bilirubin peaked up to 12, and multiple calls for a small bowel transplant were declined because the liver was not assessed. We did a liver biopsy which showed steatohepatitis, no bridging fibrosis. So these patients, sometimes if they need a liver transplant and you give them a small bowel alone, your operation will fail. So we need to evaluate the status of the liver in these patients, or they go on an emergency liver transplant listing criteria. Many factors responsible for liver disease in these short gut syndrome patients mostly is a soya bean based derivative of a lipid emulsion which causes the hepatotoxicity and leads to the liver disease in these patients. Generally in the West, the first treatment for a short gut syndrome is a TPN, or a home-based TPN. But there are very expertise and centers available, the pathways available to give them. In India, we suffer with that lack of organizational structure in giving a home-based TPN to these patients. We have a blanket products, 1 or 2 products available for 1.4 billion population. There needs to be a calorie dextrose assessment, fat ratio, which kind of fat to be given. So home-based TPN is basically a tailored approach. It's not one blanket for all. Every individual has a different needs, and it is being given according to the needs. So home-based TPN, I did a rough calculation, is costing around 1.5 lakh rupees in India per month, without including the cost of a nursing and the line care, which is almost prohibitive to more than 95% of the population in India at the moment. I would not be able to afford this kind of treatment for myself if I had in this trouble. So what is the best for these patients in India? I think it's the early referral rather than a home-based TPN for a transplant, because they lose the money in the TPN and then they have nothing left for the transplant. We get an allocation based on the blood groups. Different hospitals, different centers have a different criteria for accepting a donor. My criteria, my plan is to not take more than 40, 45-year-old, though in UK we used to take up to 60 years old. It should be a very athletic, thin donor to consider for a small bowel transplant. We can do an isolated small bowel transplant, or it can be a small bowel with the liver, with the pancreas, with the stomach, which is called a modified small bowel if there is no stomach, or a multi-visceral transplant. What kind of a donor operation has to be done, and what are the organs which need to be retrieved depends upon what anatomy we have in the recipient. This is one of the multi-visceral block which is being prepared on the bench. This is one of the patients we did, and the inflow and outflow, arterial flow and the venous flow being given with this isolated small bowel transplant. And for any transplant surgeon, when you refuse a graft and you see a bright pink peristaltic bowel in front of you, nothing can be more reassuring than this. What is the survival of these patients? 77% at 1 year, 58 at 5 years, and around 50% in 10 years, the Canadian data. Generally, overall patient survival 3, 5 and 10 years is 70, 66 and 63%. graft survival is a little less than that, but they can retransplant them if the graft fails. Why do they do a home-based TP and invest for not a small bowel transplant? Because the long-term survival is almost equal as a home-based TP and gives a 60% survival to these group of patients. And the graft failure rate is around 6 months, around 20%. The 20% of grafts can fail in your first 6 months of the time, and the most common graft loss within the first week or 1 month is the technical reason, and after that is a rejection. Acute cellular rejection is very difficult and challenging scenario in India. We have infection all over our body and in our healthcare systems, and the presentation is same. They all have a loose motion, they have abdominal pain, fever, rising markers, whether it's an infection, loose stools because of viral infection or a bacterial infection, or they have an acute cellular rejection. So we do a protocol biopsies in these patients. This is a very minimal approach. This is a biopsy at 2 weeks time. Insignificant for rejection, indeterminate for rejection. You can see the architecture, crypt distortion, inflammation. So mild to moderate rejection, and this is a severe form of rejection where there's ulceration. The architecture is gone, you can't see any crypts. This is the end of a graft loss. There are multiple ulcers on endoscopy you can see in the moderate to severe rejections. And the problem with immunosuppression, rejection is one of the problem in early phase of their post-operative period. We in Cambridge used to give them what is called Campath or Lemzumab, which literally puts you on a zero lymphocyte for at least 6 months. So you have no lymphocytes, the chance of rejection are very less. But in India, the drug is not available, so we are left with an ATG. Most of the people are not very well versed in the ATG protocols, and generally have to be given for 14 days with a 1.5 milligram per kg body weight. And if we give this much of dose to Indian patients, my nephrologists who are managing pancreas and kidney transplant, they said after 2 to 3 doses we can't give, otherwise our patient will have fungal infections in the chest and brain abscesses and all that. So we literally struggling at our stage. What is the best immunosuppression induction for this group of patients? I won't talk much about GVHD, but the 10% incidence in small bowel transplant patients, particularly if we use more so if we use the Campath as an induction agent. This is the slide of interest which I would like to emphasize on. The UK has a population of around 68 million, and they do around 20 to 30 small bowel transplants a year. If we look at Indian populations of 1.4 billion people, so we should be having around 300 transplants, small bowel transplants alone a year. Looking at the numbers, it's very disappointing, but the talk which we heard before our session from Dr. Mohan Prasad sir was exciting, that we shouldn't give up. You need to continuously have a perseverance and have a hope that one day this program will kickstart like the liver transplant started. 20 years back, liver transplant was like a no-go and a very dismal outcomes, very bad outcomes. But then those pioneers who didn't stop and continued, now it is like it's being done in every nook and corner of the country. So I hope that one day we will achieve a same department where the intestinal rehabilitation will be considered. The gastroenterologists will take up the super specialty pathways of nutrition, of immunology, short gut syndrome, because the nutrition in these patients is a clinical entity in UK and NHS. But unfortunately, nobody is pursuing the course here because there are no scopes, there are no jobs in the hospitals. So people don't opt for these courses at the moment. But I hope one day it will open up a pathway, and the small bowel transplant or multi-vessel transplant will be a reality in India. So in summary, multi-vessel transplant is a complex and a formidable operation. It needs a comprehensive team effort, early referral. We need to rehabilitate these patients. It's not like somebody has a short gut and he goes for a transplant. We need complete understanding of intraoperative and post-operative intricacies of these patients, and Indian scenario needs a dedicated organization and protocols, and stalwarts of gastroenterologists sitting in this podium can make a big initiation of these projects in their respective hospitals. There's a scope for discussing this in every forum so that the information is spread. And we need a small bowel transplant registry. We need resource mobilization to help these destitute patients. Thank you all for the patience.
Thank you, Sir, for your thought-provoking presentation. We now invite our chairpersons and delegates to chat their reflections.
So regarding the medical management of acute or chronic liver failure, we have got one role to play, that is regenerative therapy for liver. That is granulocyte colony stimulating factor and erythropoietin. If you give these patients suffering from acute or chronic liver failure, we can prolong their life and we can prepare the patient for liver transplantation. Now, another important point is whenever a patient is in alcohol dependence, there are many laboratory investigations which can find out whether the patient is continuously taking alcohol or not. That is carbohydrate deficient transferrin, gamma GT, and also mean corpuscular erythrocyte volume, and phosphatidal ethanol and ethyl glucuronidase. All these things will find out whether the patient, even though patient refuses, with these investigations we can find out whether the patient is continuously taking alcohol or not. But even for the management of acute alcoholic hepatitis, there are many novel treatments, but they are all not yet proved beyond. But one is the interleukin antagonist, that is anakinra. That is has got a role in the management of acute alcoholic hepatitis, apart from the steroids. But whether steroids, whether they are responding or not, that can be found out by Lilly's score.
Thank you, Dr. Shiraj. Actually, how many small bowel transplants in the center you have done so far?
Unfortunately, not in my center, but we did one recently in Apollo, Chennai. We have listed up some patients, and the donation rates in Kerala are very dismal. Almost last 6 months, we haven't seen any donations. And small bowel transplant donations, the donors which are given for a small bowel transplant, 90% of them are declined based on their body habitus. So it's after we get 100 calls for a donation, 5 or 10 will be appropriate for a small bowel transplant donations. We have some patients listed in our registry, but the donations are dismal. So we have tied up some associations with hospitals in Tamil Nadu. We had some association with you in Chennai also, and we hope that the Kerala and Tamil Nadu, the South Indian barrier can be broken and we can progress in this.
The transplant goes like, is it only blood group matching or does it require extra? I believe small bowel is very immunogenic compared to renal.
Definitely.
So, but renal transplant, you have an HLA match and then you take up. Does it hold good for small bowel as well?
Yeah, I didn't touch about immunology here because it's a very vast topic. In UK, we do what we call a virtual cross match. There's no actual lab cross match done for any transplant now. But these patients, these recipients have updated immunological profile. So we set a DSA every 3 months in UK. So that gets into the hub and it's updated in the hub. So when a donor is sort of identified, his HLA blood will be taken, HLA sampling will be done within 2 hours. So you get to know your DSAs. The recipient has any antibodies against the donor's blood, the DSA antibodies. Apart from the blood group compatibility, I'm talking about the HLA antibodies. But in India, we don't have that facility. It's not possible to do here. So what we do here is we do a T-cell cross match. We do what's called a flow cytometry, which is more sensitive than a conventional cross match. So the flow cytometry gives a bit more sensitivity, but it is not exactly the virtual cross match which is done basically on a computer. In Belgium, they do transplant without induction. They do a small bowel transplant without induction. That's published in their protocol. So they take the donor blood at the time of donor graft and infuse that donor blood in the recipient. But that is only after their virtual cross match is negative. So as you rightly said, it's a very immunological organ and you just lose the organ with it. It doesn't give a time to recover. So if your kidney gets rejection, liver gets rejection, you pulse them, you're back. If your bowel gets rejection, you lose the graft if you don't act immediately. The problem is diagnosing them early and then treating them. So blood group compatibility is important, but there's a criteria called preferable and compatible. So O group receives an only O group, that's the preferable one. The A receives only A, the O becomes compatible but not preferable. For B, both O and B are preferable. So it depends upon their blood groups and compatibility. Thank you.
Thank you for the speakers and the chairpersons. Moving on to the next session.
Now let's dive into an engaging session of potpourri, where we'll explore a diverse array of fascinating topics in medicine. Now I call upon the chairpersons to the dais, who are the ideal guides for steering the discussion and fostering an enriching learning experience. I request Dr. Vamsimurthy K. Sir, Dr. A.C. Arun Sir, Dr. Mohan Alayas Harmuga Pandian Sir, Dr. Senthil Kumar Sir to the stage. To begin the session, I welcome a highly accomplished speaker who is currently Senior Consultant and Clinical Lead at MGM Healthcare Chennai. He is a respected figure in the field of gastroenterology. Also, he is the current Treasurer of ISG Tamil Nadu chapter. It is our great honor to invite Dr. Arul Prakash Sir to present on the topic of biofeedback theory.
Thanks for the opportunity, and no delay, I'll just go into my topic. So it's a difficult topic because many of the practitioners are not interested, and even understanding the technique and the patients who will benefit from this biofeedback is very obscure. So we are all missing on this information. The next few minutes, I'll try to make it a little bit easier. I'll try to make you understand what is biofeedback therapy. So here in this next 10 minutes, I'll be talking about biofeedback for GA, and particularly for dyssynergic deification. So without knowing the anatomy, it's difficult. So we have to concentrate that these are the muscles which of the deifications which help us in the process, and we have to understand there are nerve endings which afferent nerves which carry the information, and the afferent nerves which relaxes the internal sphincter, and that is a central mediated relaxation of an external anal sphincter. So there are a lot of muscles, nerves has to coordinate a process of deification to make the process very easy. If there is a problem, the person presents with constipation, right. So to understand biofeedback therapy, what is biofeedback? Biofeedback is a feedback you get in from the body that what is happening inside. The simple example is continuous glucose monitoring. So you put a needle and the sample continuously, and you can see what is happening in your body. So some information from the body is transmitted to a device, and then you understand what is happening, and you titrate or do any intervention accordingly. So here in biofeedback, what are the indications? Commonly, it's dyssynergic deification or an obstructed deification syndrome, fecal incontinence, or sometimes anorectal pain. These are the indications where we can use this biofeedback. So this is the basic. Please understand. It's particularly important for us to know any behavior, whether it's a complex maneuver or not, which is reinforced and repeatedly done, and it's more likely that it's perfected. Like say you do some exercise, you do one procedure or one step for n number of times, you become an expert, something like that. So you have to understand deification process, it's not a conscious or actually conscious process. The aim is to learn the process through an instrument and make some voluntary changes in the habit or the exercise or positioning what we do with the help of the instrument, and then you take out the instrument and do it on your own. This is what biofeedback means. So what is this equipment? It consists of a sensor which is in the anorectal area, detects the patient's activity, amplifies and transmit to either visually like on a screen or an auditory signal like yes it's done, something like that, or a physiotherapist or a doctor's encouraging, yeah you have done very well. So that response has to be done. So it's visual, auditory and verbal feedback. So the instrument is doing its job and giving you back the feedback, and then you understand and do it accordingly. So what does it do? It corrects dystonia. We can increase the erectile sensation and coordinate the pelvic muscles, which helps in the process of evacuation. So what are the types we do? Through anorectal manometry, and other through an electromyography guided biofeedback therapy. The manometry is the commonest thing which we all have but seldom we use because the expertise and the knowledge and the training is not available, or the time spent with the patient is very less, so we are not doing it. It's simple. The conventional manometry probe is placed and the patient is asked to see the screen and observe the changes, and whatever positive changes we have to educate them and do it accordingly. EMG biofeedback is nothing but placing a surface electrode in the anorectum or the other electrode in the butt or abdominal wall and ask them to strain and see the changes on a visual screen. So these two biofeedbacks are done. This is the manometry where we normally use. It has a sensor and it is amplified and brought as a signal in the computer. Now you have beautiful color-based recording so that it's very easy for anyone to interpret what they want. So what is the protocol? We have to know, like there is no standard protocol now, but what generally we should do is have to assess the patient, do a good psychiatric counseling, because most of them has a lot of functional component. You know, they will be depressed to the core. Even if you ask them to wait for 3 hours in the OPD, they won't make a fuss. So they are suffering, say they want some solution. So you get into deep of what they are suffering from, ask them to maintain a stool diary, evaluate them completely. If somebody is referring, please do an anorectal manometry again. Teach them diaphragmatic breathing exercise. Give them good laxatives and toilet training, which we will be handling. So this is what generally everybody has to understand, not even for dystonia, but rest of the thing. So avoid medications and diet which can increase constipation. Average fiber intake 30 grams and good fluid intake, minimal exercise activity, and timed toilet training is very important because you have to attempt a bowel movement at least twice a day, and it's in early morning after meals. Not to sit and try for more than 5 minutes. If you do more, it's not going to work out very well. And the push level or straining should be like 5 to 7. If you can max strain with 10, you should not do that. So maximum try to 5 to 7, and refrain from doing digital evacuation or disinfection or enemas. So the preferred laxatives, everybody should be on laxatives, though they have soft stools or something, because that should not interfere with our process of biofeedback therapy. So you use osmotic laxatives, which is very good in this case. Fibers are not very good, and it can increase the bloating the patient is already having. So osmotic laxatives are preferred. The second part, we analyzed them, we gave them laxatives, we spoke to them, and then phase 2 is an active exercise where proper defecation process is happening. So patient posture should be corrected. You know what happens when you sit on a Western toilet commode, you have your hips on 90 degrees with the body, it doesn't work. So Indian type of sitting is always good. So you can use a toilet stool and you have to bend forward a little bit and breathe. So diaphragmatic breathing exercise is very important. It's very simple. So whenever you inhale, the abdomen part has to come out. So that is called diaphragmatic breathing. So when you strain, the abdomen part has to come out. So many a time when you ask the patient to strain, they will bring their abdomen wall in to force it, but that is not the right way to do. The pressure is not transmitted appropriately. So you have to teach the diaphragmatic breathing technique. They can use it any other time also as well. And the patient posture is also top. Then comes the proper biofeedback, which we will go to. Recto-anal coordination. You know what it looks like in anorectal manometry. This is the anus and this is the rectum. So during trying to push, the pressure in the rectum is increasing and there is a decrease in anal pressure. So in dystonia, what happens? Rectal pressure is increasing, but anal pressure is also increasing. This is a classical type 1 dystonia. So there are various types of dystonia here. So this is what visual biofeedback. So this is what we have in our instrument. So what we do is So I'll tell you simply. See, there will be two columns. One is anal pressure and rectal pressure. You put the anal pressure in whatever target you want. Like say 40. The baseline is 40. So you can keep in the lower part, and then the red is not we want to achieve. We want the green. So when you ask them to push down or veer down, I'm not able to run this video, sorry for that. So we have to ask them to keep these two columns in the green while attempted defecation. So if they are getting red, that's not good. So once they get the green, they will understand what they have done. So they will try to repeat it. So each session will go like 10 or 15 times they can try, because after that there will be a fatigue. So you don't want to do it again. So later on we can call them and do it. The other thing is stimulated defecated training, which we are not doing practically. What is fill the balloon with 50 ml of water so it's heavy, and ask them to sit on the commode and attempt the defecation. So every time an anorectal coordination by visual biofeedback and then a simulated defecation, which they can do it on a commode in a proper way. Not a lot of facilities have this thing, but we have to attempt at least in one area. You should have a person who can handle such things. And rectal sensory training is many a times what happens, the rectum gets distended, and because of chronic constipation, they don't feel that stool is in the rectum, so the constipation worsens. So what you have to do is do a rectal sensation by a balloon and then decrease 10 ml of water every time and ask them to perceive. So slowly what happens is they have to perceive lesser volumes of balloon. So that is the target. So this happens as a slow process. So we have to take time, and the rectal perception in phases. The phase 3 is weaning and reinforcement, where we have to do it in the sittings of like at 6 weeks, and again 3 and 6 and 12 months, and slowly without biofeedback. So there are a lot of studies have shown biofeedback therapy is more effective in differential defecation. And the AGA and the Neuromotility Association has advised as the first line management. So in summary, it has limitations and challenges. You need a proper equipment and place, and a person who can spend time. There is no planned protocol. You need a good pelvic physiotherapist. It's labor intensive, and it doesn't have much side effects. And there is no immediate reward, so you have to explain them, keep them in confidence. We don't have much centers to offer. And anybody can identify this person? Sorry? Satish Rao. Yeah. He's the person who has done a lot of work in mitigation. If you look in literature, he has done a lot of works. And anybody interested can follow this and have a setup separately for these particular group of patients, which will be very rewarding. Thank you. Thanks for paying.
Thank you, sir, for delivering such an outstanding presentation. Our next speaker is a woman of virtue and simplicity who brings a wealth of experience in hepatology and critical care. She has dedicated her career to advancing the management and prevention of liver diseases. It is an honor to invite Dr. Hemamala Ilango ma'am, founder director of Liver World Chennai, to present on the subject of unusual relief.
Thank you for the kind invitation from the ISG team. So Dr. Shafiq called me and asked me to talk on unusual relief. So I asked, what does it mean by unusual? He said, don't talk about the usual ATT and chemotherapy, something uncommon. So then what is common? So this is the study by Harshad, published in 2010. So what are the common etiologies of drug-induced liver disease over previous 15 years in 2010? So ATT was almost 60% of cases were from ATT, and all the rest single-digit numbers. So and then here in the bottom one you see something like would be 5.5, then rapidly increased to 10, and then OTPT was in the early 1000s. She has lost some weight. So again, we go through the full evaluation as for a chronic hepatitis or acute hepatitis. She has some oral ulcers or joint pain. But all the evaluation was normal except for mildly elevated IgG, and so the liver biopsy was suggested. So by the time she came for biopsy, it was almost 1 or 2 weeks later when she came back for biopsy. We had asked her to stop all medication with whatever she was taking, and then by the time she came for biopsy, in 2 weeks, she said she is feeling better. We had asked for another camp, but she refused at that point. And then, as usual, the pathologist will give us the findings in the liver, but we have to correlate clinically. So some spotty necrosis, some lymphocytes, few eosinophils, and then there was no fibrosis. So this was their diagnosis, and they said vague rosette formation is there, so maybe it is autoimmune hepatitis. So when we called her back for the discussions, I said this looks like autoimmune hepatitis, but clinically she is feeling better, and the LFT was started regressing. At that time, it was 2022, there's lots of COVID cases and people were taking Geloy. So he said, sometimes people are taking so many CAM, like Geloy. Then he said, yes, I have been taking Geloy till a month back and I stopped. So this biopsy is typical of autoimmune hepatitis. The patient had stopped all medications about 2 weeks back. Clinically, she was improving. So then I said, okay, we'll observe. So we are not going to say, otherwise by this biopsy, we should start on steroid. We said we'll observe. And within a week or two, it dramatically came down. In 2 months, it was completely normalized. So in this case, probably there are multiple reasons for the liver injury. So obviously some CAM was there, the nitrofrantoin. So it is also known to induce AH. So drug-induced AH, one of the causes is nitrofrantoin, and then also Geloy. So Geloy was very commonly used during the COVID period, and after the publications first from Abha Nagral and then from the multi-center study from AIG, so it is well known now that this can cause autoimmune-like features. So we should, discourage people from taking. I think in Tamil it's called as Amrutavali, I think so. Case 2 is also seen initially in 2022. She was a breast, operated in 2018, and then she was doing well. She was on tamoxifen 10 mg daily. So, and then after 3 years of surgery, they noticed some transaminase. She was slightly obese. I think she was, her DNA was around 28. So her initial ALT was 196, 115, and then around April it increased. And she had fatty liver, and as I told, her DNA was slightly on the higher side. So the differential diagnosis here is obviously NASH, or what we call as MASLD now, with steatohepatitis. So liver biopsy was done, and it was, the NAS score was 648, that means definite NASH, and the fibrosis score was 2. So, but here tamoxifen is also known to cause fatty liver and also in some patients steatohepatitis. So she was asked to stop tamoxifen initially. And then, this was the April values, and then within 1 month it came down very well, even without any treatment. So this is not a pure metabolic dysfunction associated fatty liver, but it is a drug-induced fatty liver. So, and then she recovered uneventfully. So she is now on follow-up. I think last stiffness was, LSM was 10. So these two patients, they did relatively well without any intervention from outside except for, stopping the drug. So the tamoxifen is an anti-estrogen, and usually steatohepatitis can occur up to 1/3 of patients. Acute liver injury is rare, and then other liver injuries can occur is the porphyria cutanea tarda. Other drugs which can cause fatty liver is methotrexate, amiodarone, or 5-FU. And then case 3, she is a 36-year-old lady who was on anti-HIV treatment, heart therapy for about 10 years. She was relatively asymptomatic. She was initially seen in December of 2018. She came with jaundice and itching for about a month. And her peak bilirubin was 18, AST 18, 700, 800. And she was started on a medicine called as Triode, which is a combination of lamivudine, tenofovir, and efavirenz about 3 months back. So this was presumed to be a drug-induced liver injury, and she was asked to stop, but she did not really improve. After 2 weeks of stopping the drug, she was changed to another antiviral, and then so liver biopsy was done. She had some rashes, also itching. So it shows chronic hepatitis pattern with lymphoplasmatic increase and some eosinophilia. So because she did not improve, so we started her on steroids, and after starting her on steroids, it came down within a week. She showed a very good improvement, and then LFT normalized by 3 months. So and then ART also was changed to Viropil. So this is an efavirenz induced DILI. Around 1 to 8% of the patients with efavirenz can cause transaminases, and this is a hypersensitive type of liver injury. So these patients may benefit with steroids, if the injury is severe. So case 4 was a little bit more long drawn. She was another 35-year-old lady. She came with jaundice of about 3 months. She had initial improvement, then she worsened. In fact, she came to us for, actually she was referred for liver transplant, and her brother was also willing for to be a donor. The only other past history was she was treated for menorrhagia for 1 month. 1 year, sorry. 1 year. On and off she was getting treatment for menorrhagia. And this was her peak bilirubin had initially gone up to 22, 23, and for some reason it had come down after some time. Enzymes were around 300 to 400. So all the evaluation also was done. Her INR had initially increased and then it came down. So when she came here, her bilirubin was around 22. OTP had slightly come down, but still high bilirubin was there. In addition, for her, actually, some vascular lesions were seen. Her AFP was high, 508, and there were no varices. Immuno-IgG was slightly high. The autoimmune markers were all negative. So she was evaluated for transfer, but she looked relatively well. Her platelet count was maintaining. She had some itching. So so they're still wondering what is the reason for liver injury. All the workup was negative. So we went ahead and did the liver biopsy for her actually. Even AFP was high, so which showed mainly neutrophils and bile ductal proliferation. So cholestatic injury was there. So I will skip all these. This is CK19 showing the bile ductal proliferation. So with some periportal fibrosis, this is a MAT screening shows is showing F2 fibrosis. So in her, we started her on steroids. So this year, we presume that she probably has drug-induced liver injury from the progesterone or estrogen which she was taking for the menorrhagia, and she was taking it on and off. That probably explains some waxing and waning of the, the LFT. And she was started on steroids, and within 2 weeks it came down to half, and then LFT normalized in 3 months. But in her case, I had dilemma whether there was autoimmune hepatitis or it was pure drug-induced. Wondering whether to put her on Azaran or not. I think I did put her on sometime, but after 1 year she again developed menorrhagia. At that time, at her hometown, somebody had started, and then it started climbing the OTPT. So then it is clear that what she had initially was also drug-induced liver injury. But now she is doing well. Now it's 5 years. Her liver stiffness is also normal. So this is probably the hormone induced. And case 5 is like a neat PG question. So a 36-year-old lady referred for multiple tumors on routine scan, absolutely asymptomatic, slightly obese. The only thing which she forgot to tell the doctors, or probably she herself forgot, was that she was on OC pills for the last 10 years. And the CT and MRI were, imaging-wise, it is suggestive of hepatic adenoma. So multiple circumscribed tubers in both lobes, and the biggest one was in segment 6, which was around 3.7 centimeter. So because there was a history of OC pills, all the other tumor markers, everything was normal. So we asked her to stop the OC pills and asked her to come back for a review. And when she came back for review after 6 months, the size of the lesions has significantly come down. So so this was a OC pill induced hepatic adenoma. So we saw some of these, around 4 or 5 patients. So basically, drug-induced liver injury, we all know it's a diagnosis of exclusion, and this is a criteria which is used. We don't use it on paper at the bedside, but basic concepts we all use. How long after starting the drug, what happens when we stop the drug, is there any other competing causes? All those things we do it, and there is what happens if we re-challenge. Re-challenge is not always possible, especially if they present with jaundice, because sometimes it can be fatal if you re-challenge. But for minor cases, probably we can attempt it. And is there a role for liver biopsy? Most of our patients have undergone liver biopsy. Whenever there's a in routine dealing, we don't need a liver biopsy. So whenever there's a diagnostic dilemma, or if there's some other cause which can be coexisting, or if there's lack of clinical improvement, or there's recurrence of symptoms and signs, then we can go for liver biopsy. So general principle management of DD is actually stopping the drug. And then for cholestyramine, UDC and NAC can be used if the liver injury is severe. Steroids in selective patients. Hy's law, you all may be familiar, PGs. So this is an observation by Feynman Zimmerman, who is an authority on DD. So basically, if you have jaundice and if you have hepatocellular injury, then the risk of mortality is around close to 10%. So those patients we should evaluate very quickly, and we have to have high risk of suspicion. So steroids in BB, some evidence the systematic review says benefit few subset of patients, especially those with hypersensitivity drug reaction. That means those with rash or eosinophilia or systemic symptoms. Those patients may benefit the steroids or drug-induced AH and immune checkpoint inhibitors or biologicals. Those patients, steroids may be useful, but in generally it is not indicated.
One question. How often do liver function test when starting the rheumatic drugs? Like long-term use of tamoxifen or ART. How often you have to do liver function test?
So depending on the drug which is used for ART, I think they have given guidelines are there. So initially once a month, then once in 3 months, then once in 6 months, and I think after 18 months, once in 6 months is enough for ARTs. For tamoxifen, generally it is not indicated. Once in 3 months is fine. Because metabolic factors also plays a role for that factor even in tamoxifen in the breast cancer patients.
Thank you, ma'am, for sharing your invaluable expertise through an enlightening presentation. As our final speaker of the session, we are delighted to welcome an accomplished clinician, currently serving as the Associate Professor and Consultant Gastroenterologist at AVMC Pondicherry. His deep knowledge and research on gut microbiota will provide valuable insights into today's discussion on gut microbes in non-GI diseases. With great honor and pleasure, we invite Dr. B. Vinod sir to the stage.
Good morning. Outside, I would like to thank the organizers, Dr. Shafiq sir and Dr. Kadasamy sir, for giving me this opportunity. My topic will be gut microbiota in non-GI diseases. This will be a little non-linear, and it is a classical potpourri, and I will try to make it a little simpler. So I would like to ask you questions from the audience. Can you tell what is petrichor? Anybody? It is related to microbiota. This is smell after rain. Petrichor. It is due to geosmin produced by Streptomyces bacteria. So next slide is, the next picture is, what is it? Swiss cheese. Is it, I will guess, the most delicious cheese in the world. It's white. It's because of the microbiota. Propionobacterium present only seen in the Swiss forms. Okay, that is the reason why, and you can see the pores only in the Swiss cheese. That is because of carbon dioxide produced by this propionobacterium. And the last thing is, last two slides shows the taste depends on your hands or what? The taste depends upon the different individuals. So you will not get the same taste of your mom from rest of anywhere in the world, because that is because of the microbiota seen in the hands of mothers. Okay. So with this introduction, we will go into the topic. So we actually harbor more amount of cells than our human cells. Actually, a 70 kg average man actually harbors 39 trillion bacteria, and our body actually has only 30 trillion human cells. So we harbor more than our body cells. And 20% of all the metabolites seen in the blood are produced by our microbiota. And we have more than 2,000 different bacterial species, and apart from viruses and fungus in our intestine. Actually, we gather information about the microbiota through our latest technologies like biomarker profiling. The composition of the bacteria is done by NGS, that is new next generation sequencing. With this technology, we used to find the composition. Actual composition of the bacteria is done by this technology. And metagenomics, we find used to study the microbiome functional gene capacity. Again, this is the next generation sequencing using next generation sequencing. Metabiomics is used to study the metabolic productivity of the microorganisms. The platform used is liquid chromatography, gas chromatography, and mass spectroscopy. And metatranscriptomics is used to study the microbial functional gene expression. This is based on the RNA study, all the others are DNA. And metaproteomics is study about the protein expression. So using all these techniques, we can find out the composition of the bacteria, their metabolite production, and their functions on our human body. So our microbiota starts developing even in utero, but immediately after delivery, based upon the delivery, whether it is vaginal delivery or cesarean section, our microbiota differs. And later, when we are when feeding starts, again based upon the feeding, your microbiota changes. Breastfed infants, the microbiota is different, and formula fed infants, the microbiota is different. And again, various diet influences the gut microbiota, and the exposure to environment like toxins, tobacco smokes, etc. can influence, and pet animals in the infancy and the childhood period also influence our gut microbiota, and the use of antibiotics and our genetic predisposition. All this actually helps in forming your gut microbiota. Usually, diversity is important actually. We should have more different species in our body. There should not be any monopoly. So healthy individuals will have different types of microbacteria, and non-healthy individuals will have concentrated microbacteria. So there is always unity in diversity. So it's always better to have a diverse microbiota in our gut. So this is the pathophysiology. This is quite complicated. The left side is quite complicated. The right side is a simplified form of pathophysiology, how it functions. You need a substrate for the microorganisms to grow. The substrate is the one which is important. So that is the food we are going to provide. So whatever you eat is going to be the substrate of the microbiota. And based upon the pH, substrate available, the organisms grow, and they actually produce certain metabolites like pathogenic antigen molecular associated protein, PAMPs, and then carbohydrate, amino acid metabolites, lipids, and the endobiotic metabolites. They produce certain metabolites and substances. They go and stimulate the T receptor cells present in the lymphatic tissues around the epithelial cells, and they also move to the other organs, breaching the barrier, and they go to the distant sites like liver, brain, adipose tissue, respiratory and cardiovascular system, and they do various metabolic functions. So this is the way how the microbiota functions. So these are the metabolites produced by the bacteria and their functions. Butyrate, propionate, various organisms produce various metabolites. Actually, this is very difficult for you to memorize. It's very difficult for me also to still individual organisms causing individual metabolites. So the metabolites are basically butyrates, propionate, and indole, and indole aldehyde, indole propionate, HYA, that is lipid metabolism, and CLA, linoleic acid. So these are the various organisms producing various metabolites, and the various metabolites have various roles, okay, in our organisms, in our body. Like they maintain the gut barrier, and they maintain the immune system. They improve our immune system, and they also various production of IgA. IgA produces certain bacteria, and they increases the insulin sensitivity. So they have various functions. So whenever there is gut dysbiosis, whenever there is a problem with microbiota, then actually these metabolites are either missing or they are in abundance. So they cause various problems, various diseases, usually chronic inflammatory diseases. Whenever there is disease, there is no particular cause for a disease like diabetes, obesity, SLE, or skin disorders, where there is not a cause and effect pathology. Probably this gut microbiome also plays a role. Okay, example, skin diseases like psoriasis, vitiligo. So those diseases can occur because of gut dysbiosis. And type 1 diabetes, systemic lupus erythematosus, then multiple sclerosis, then cognitive disorders like autism spectrum disorders, anxiety. They can also influence CNS cognitive disorders, and then thyroid disorders like Hashimoto's thyroiditis and Graves' disease also can be influenced by gut dysbiosis. So the same is mentioned here, and the pathophysiology is also mentioned. We can't go into the details of this. Graves' disease, Hashimoto's thyroiditis, multiple sclerosis, type 1 diabetes, systemic sclerosis, psoriasis, psoriatic arthritis, scleroderma, and vitiligo. And apart from this, obesity and type 2 diabetes also has been has been reason for the gut microbiome can cause type 2 diabetes, aggravation of type 2 diabetes and obesity. Actually, this is one recent review article where I was a co-author. We have written this review article. This is biofilm mediated integrin activation and directing acceleration of colorectal cancer. Gut microbiota has shown to increase the development of colon cancer. This is a meta-analysis. This was published last month. Recently, the role of gut microbiota in cancer therapy is upcoming. They have shown that cancer patients responded better if there is more diverse gut microbiota, as I told earlier, and if they lack bacteria like Akkermansia, Mucinophilia, and Faecalibacterium and Bifidobacterium, they poorly respond. They also showed that mice transplanted with fecal microbiota from responding patients, they improve following cancer therapy, and if they give bacteria depleted in patients with non-responders, they respond to the therapy. So these are the various therapeutic options available using the microbiota. First, we can try antibiotics and antifungals. They reduce the overload. That way, they can improve the patients on certain diseases. Then, diet modulation also is important because what we eat provides. They behave as the substrate for these microorganisms. So, diet modification is one of the modality. Second is prebiotic. The specific nutrients required for the specific organism. That is prebiotic. And probiotic, the exact organism, and last but not the least, the fecal microbial transplantation. So these are the options available for dealing with all these diseases. Few examples are diet rich in fiber was shown to improve patients with type 2 diabetes, and combinations of bacterial strain is used to was shown to improve type 2 diabetes and hyperglycemia, and supplementation with the same consortium feeding led to significant improvement in fatty liver disease and reduce body mass index and increases the glucagon like rectal levels in children with obesity. LGG, lactobacillus species, has improved peanut energy in children, and the most important thing is we should enhance the nutritional support. Actually, that is targeted dietary modification. It has to be individualized. So, for a person with a different disease, we have to give personalized nutrition, personalized pertain to that bacteria which you are going to give. That will give a better response. So fecal microtransplant proven effective in more than 90% of the patients with recurrent Clostridium difficile infection. In children aged 7 to 16, it has shown improvement in autism spectrum disease. And if you transplant a lean donor microbiota to obese patients, they show improvement. To summarize, advanced techniques we have nowadays to better understand the gut microbiome. Gut dysbiosis is observed in certain chronic diseases. Gut microperturbations, that is problem with this gut microbiome, are evident years in advance to disease development, offering biomarkers for early detection and disease risk and opportunities for preventive interventions. Positive results have been observed for some diseases, indicating following efforts to rehabilitate this disturbed gut microbiome via dietary intervention, microbial supplementation, and fecal microbial transplant. Thank you.
Thank you, sir, for shedding new light with your extensive knowledge. Now the forum is open for discussion. We invite our chairpersons and audience for any questions or insights you'd like to share.
I have one controversial question for Dr. Hema ma'am. What is your take on the herbal medicine Keelanelli? Very often we hear about that. Does it really do any benefit, or is it again will cause any delay?
Actually, I think we do not know, but probably it's most of the time it is probably used for acute hepatitis or alcoholic hepatitis, where it may help from liver regeneration. I think maybe some publication may be there, but I don't think so. We are in a position to recommend taking it, but sir might have more.
I'm talking from history.
Yes,
actually, Doctor.
It's probably, I think it is harmless. That is Keelanelli, but it is probably harmless provided they know that they are taking Keelanelli. That means it should grow in their house people should know it is Kiranali. We should not buy it from the market saying it's Kiranali. That can be harmful, that can be mixed, we do not know what. But if somebody knows to identify that Kirai, I think probably it's okay, but it is not a medical...
It's not a panacea for all. But Blumberg did studies on Kiranali along with Dr. S.P. Tyagarajan and with Professor Madan Gopalan. I'm talking about when I was a student in 1985 to 87, at that time. You know, already they did research, they showed even in vitro, laboratory, and also in patients, Kiranali helped in hepatitis B, in inhibiting the virus, even in vitro. But S.P. Tyagarajan's reports are there, and Blumberg, you know, is a joint author. So Kiranali works in hepatitis B. So, but it's got a marginal benefit. You know? It's a very weak drug. So, and as the man put it, we should have a purity of the product when prescribing. Many a times, this Ayurvedic concoctions have too many herbs inside. Like for example, Live 52. They published, you know, like 1990 ISG National had a paper on electron microscopy of Live 52 with alcohol, pre and post liver biopsies. They're looking at mitochondria in the cells. I don't think that's that's too much. So,
thank you. I have a question now. In patients with obvious hypersensitivity like rash, fever, eosinophilia, we are convinced to start steroids. Whereas the immune-mediated hepatitis, where there is no much hypersensitivity features, how are we convinced to start steroids? Do we have any cutoff beyond which okay to start steroids? In significant cholestasis, we are convinced to start steroids. But the hepatitis fellows, we are afraid of sepsis as well. So what is the cutoff? Like in alcoholic hepatitis, you have some cutoff. Similarly, is there any data for that?
So, actually, you have to look at the overall liver function. If the patient is not decompensated, the INR is not wrong. That means we are talking about melt below 25 or something. And you know, because if we are not treating, how is the progress? Over 2 to 4 weeks we can wait. No, because otherwise, what is the option we have? We have only the transplant as an option, then we are looking like that. Those patients, liver biopsy would help, because if they have eosinophilia, maybe I will be convinced more towards starting steroids. The bilirubin is not coming down for 4 weeks, maybe I will be more convinced, as long as INR is not prolonged. The INR is prolonged means the liver is failing, the incidence of complications will be high. And also, if you do a biopsy, you know the fibrosis. If the patient already has cirrhosis, probably it's not wise to start on steroids.
Thank you.
How often do you use exogenous fluoride?
I don't think I have used that much, but...
Because I have been using this snack, right? So
Yeah.
it is going to be converted to glutathione and then it's going
Yes,
to
yes,
on
yes.
the...
I know there are, but I have not really used that much, but I have seen patients come with that prescription, and if outpatients I don't really change it. And I have not personally used that much. Probably NAC is the only one which I have used. Probably likely to be
snack has to
helpful.
be converted to glutathione, has to be on the... So often...
a very fond user of glutathione intravenous. So it's the life giver, you know, like free radical scavenging it does. 600 milligram IBBD is the dose that I use. So the tablet glutathione is orally when taken doesn't reach significant pharmacologic values in the blood. So blood levels do not achieve optimal level. So but intravenous, yes. So of course, N-acetylcysteine gets converted to N-acetyl glutathione. That's how it works. So it should work, probably.
So regarding biofeedback technology, innovative technology, so what is the complaints of the patient?
So generally, it's a long process. The patient gets a little frustrated because even the day one they don't get better or in a weeks. So it takes months together. But we have tried in few patients with visual, they can see that yes, there will be a change. So they have to persist on that. They have to come back again and again and make the changes. It has to come from the patient itself. But when a person is expecting drastic changes in a day or a week, it's not going to happen. So most of the failure is because poor patient confidence.
And they do at their home.
Yeah, you can, once you learn what to do, like relaxing or something, relaxing muscle, they can continue it at home. So that's why we have the reinforcement for every 6 to 10 weeks and then 6 months. We call them back to just reinforce, okay, what you're doing is right, you need to change a little bit. But it needs a lot of time to be spent with a person, and you need a pelvic physiotherapist for that. Thank you.
So Dr. Vinod sir, of late we get very recent reference from dermatologists for urticaria, chronic urticaria, and for H. pylori eradication or something. What is the association?
H. pylori actually has been indicated in certain skin disorders actually. Proven cause and effect is very difficult. We can just empirically we can treat them on if they are positive. Test and antigen, stool antigen you can test, and if it is positive you can afford to treat. Or endoscopy, if they have some GI symptoms you can do, and RUT you can get. If it is positive you can try. Other than that it's very difficult to.
Empirically you cannot give.
Yeah, definitely difficult.
Shall I add one point? Regarding this biofeedback, sir was telling about pelvic physiotherapist. Not for marketing, but having seen true benefit, Jogo does a good job. They have dedicated pelvic physiotherapist. You can send the patient to them and they will charge more, 1,000 rupees per session. And they will do 8 session, weekly session. And patients all come out very well. They are all already some functional component, depressed, so many other anxiety, so many things, everything they will address apart from doing the pelvic physiotherapy. So they really do a good job.
Same experience at VGM also. We also go to that Jogo. Yeah, they do a good job.
They are nothing but a physiotherapist, which they are inclined to do on urogynecological work. So we can identify our local physiotherapist, ask them what to do. They just teach some breathing exercise, nothing big. They don't have a feedback instrument. The feedback instrument, what we have in our anorectal manometry, which Redistock has applied, they have a software for the biofeedback. Yes, you can do it and ask the physiotherapists to spend the time, because we cannot sit and talk to them. Like say, do this. You can just encourage them once you see them, okay, you are doing well. The rest of the thing has to be done by the technician or the physiotherapist.
Single strain probiotics. Yeah, usually only in GI disorders actually it has been proven. In non-GI disorders it's very difficult, like ulcerative colitis and Clostridium difficile, like antibiotic induced Clostridium difficile which is resistant to treatment. You can give Clostridium one particular strain. That is that will, if there is a cause and effect, if it is proven, then we can try. Otherwise it's difficult. It's more of a complementary or supplementary treatment so far. So lots of research has to be done. So only few conditions we can use. Antibiotic induced Clostridium difficile infection.
Now going towards genomics, transcriptomics and all that. So I'm just trying to, with nutrition, you can modify the gut flora. I had one patient who used to come from Vietnam, and this lady was 10 years my patient for 5 years. All sorts of things we tried. Finally, I put her to this gut eye care. So 2 years now, absolutely she's free from all drugs. She responded so well to dietary modification. Again, after 3 months, they redo the flora and show the change in the from the good health bacteria coming up and the bad bacteria going down.
It's time to bring this session to a close, and I'd like to express my gratitude once more to our speakers and chairpersons for enlightening us with their profound knowledge.
Last but not least, we are heading to our last session, which is community GI. I request Dr. Ramesh Bhubadi sir, Dr. Chanduran sir, Dr. Padmanabhan sir, to address as a chairperson and come to the dais. Cancer has become the most threatening disease in all over the world. The survival rate of the cancer patients have increased in the past 2 years. Now let's welcome Dr. N. Tirumurthy sir, who is a medical gastroenterologist and interventional endoscopist, currently working as an assistant professor in the Department of Medical Gastroenterology in Cancer Institute, Adayar, Chennai. I request sir to take up the stage.
Good afternoon to all. I thank the organizers for giving me this opportunity. I will be talking on this current status and challenges of GA cancer surveillance in Tamil Nadu. Before going into the topic proper, I would like to say a few words about screening and surveillance. They are not the same. The screening is nothing but an active search of disease among apparently healthy people, and it is considered as a secondary prevention. Whereas surveillance is a systematic and continuous collection, analysis and interpretation of data closely integrated with timely and coherent dissemination of the results and assessment. They are not the same, but often they are used interchangeably. But if you, in the broad sense, if you have to say, the screening is one of the part of the surveillance, that we can say that surveillance is a broader spectrum. So the prerequisite for any screening program or screening test should be the disease should represent the major health problem, and that should be recognizable later or early asymptomatic stage, and natural history of the disease should be known. There should be effective therapy, and the screening test should have good sensitivity and specificity, and should be acceptable, repeatable and easy to perform, and should be cost effective. So now coming to the GA cancer, GA cancers are on the rise world over, especially colorectal cancer and gastric cancers. Changing lifestyle and the dietary habits are mainly responsible for this increase in cancer incidence, GA cancer incidence in the population. As far as India is concerned, we have only tumor registry based data on the incidence of GA cancers in India. There is no population based data. So then when we have only tumor registry based data, then we have we'll like to have a lot of questions. Of these two important questions we have to ask. Really the GA cancer incidence is high in India, and if it is so, do we need any screening program for GA cancers? To answer this, I would like to give you some statistical data, and then we will discuss whether really it is needed or the incidence is high or not. So for giving the GA cancers in world and India Tamil Nadu data, these are my sources from where I have taken the data for India and Tamil Nadu. It is only Tamil Nadu Cancer Registry Project. It is mainly run by the Cancer Institute and Indian Cancer Registries and Globocon and other WHO articles, of which the TNCRP, that is the Tamil Nadu Cancer Registry Project, covers the maximum population, that is headed by the Cancer Institute. So all GA cancer incidence statistics, normally any incidence of cancer, to give the data, they use the word age standardized rate per 1 lakh population. That is across all the cancers, they use the word. So in India, the world GA cancer rate ASR is 46.9 per 1 lakh. In India, it is 19.6, Tamil Nadu 15.1. All this data, whatever I am presenting, they are tumor registry based, not the population based one. As far as the esophageal cancer is concerned, the ASR for India is 4.7 per 1 lakh. For the world, it is 6.3. For gastric cancer, it is between 3.8 to 5 per 1 lakh population. For the colorectal cancer, the worldwide it is 18.6 per 1 lakh population. For India, it is 4.9. It is variable from 4 to, it goes up to 8 in India. So the projection studies have shown that colorectal cancer incidence is gradually increasing, and it is going to increase in future as well. That is clearly, it has been demonstrated. It is increasing, and its incidence as well as mortality, definitely it is going to increase in future. GA cancer for the Indian registries, in this diagram you can see mainly the esophagus, gastric cancer and colorectal cancer constitutes the maximum load of cancers in India. These are given by the various, on the side you can see the various cancer registries from Mizoram and Delhi, Pune, Chennai and other things. These are the cancer registries. They collect the data mainly based on the hospital records. And as far as the Tamil Nadu is concerned, this diagram is showing the district-wise distribution of ASR, age standardized rate of cancer, GA cancers. Again, this is the distribution. Again, in Tamil Nadu, you can see the esophagus, gastric cancer and colorectal cancer constitutes the maximum GA cancer of in Tamil Nadu. If you see the individual side-wise esophagus, stomach and this thing, the ASR in Tamil Nadu is esophagus 2.6 per 1 lakh population, stomach 4.5 and colorectum together it is 4.3. GA cancer constitutes 7% of all cancer incidents in Tamil Nadu, and stomach and large bowel cancer are the predominant site of cancers in Tamil Nadu as well. In Chennai, where the maximum population covered, you can see the trend of GA cancers since 1995 to 2019. You can see the colorectal cancer significantly increased from 4.4 to 6.4. So in brief, whatever I have shown so far slides, in brief what we have to understand this thing is the age specific, age standardized rate for world, India and Tamil Nadu. That all cancers in Tamil Nadu it is 15.1 per 1 lakh, esophageal 2.6, gastric cancer 4.5 and colorectal cancer is 4.3 per 1 lakh population. So now come to what is the importance of GA cancer screening or surveillance? Because the incidence is increasing based on available tumor history based data, total number of cases, unreported cases, projections, and there are a lot of cases not reported. If you take all these things in together, we can see even the reported data shows there is an increase in incidence of GA cancer. So if you have unreported cases, other cases, if you include everything, definitely the GA cancer incidence is high. Unfortunately, GA cancers are diagnosed relatively late stages because of its luminal structure. Majority of the time, it won't give any much of symptoms in the early stages. Morbidity and mortality increases in late stages, and limited treatment options will be available if it is diagnosed at the late stage. And the early diagnosis and minimally invasive endoscopic surgical curative treatment is possible in GA cancer. That is important one good aspect about that. Why we should consider about screening or surveillance of GA cancer. One is the incidence is increasing, and we have the option of early diagnosis and treatment. So the various screening modalities available for GA cancer screening is endoscopic procedures, fecal testing like fecal occult blood test, immunochemical tests, serum markers and imaging. So, but the data showing the cancers are increasing, but still we don't have any screening program or surveillance program for GA cancers in Tamil Nadu. In fact, in India there is no surveillance program. What are the challenges for screening or surveillance? Because that is one is because of lack of real data on cancer incidence, and real disease burden is not known. Without population-based data or disease burden data, what is the cutoff incidence rate at which the screening test should be done? It is still debatable. There is lack of consensus on this point. Really, if you see the data, it shows it appears it is less, but in the on ground the cancer incidence is high. Then what is the cutoff? Where we should start the screening from? That is a debatable one. There is no complete consensus on this issue. And another will be access to the screening. Then there are barriers for starting a screening program, that is socio-economic myths about, especially for the cancer. Even now people are there, they reluctant to use the word cancer. If they use the word cancer, they don't come into the cancer hospital for other illnesses. No, if I come to cancer hospital, I may get cancer. That is what still a lot of myths, even in the educated people it is there. Then ignorance, negligence, the awareness and education. And there is a lack of consensus among healthcare providers. Among ourselves, there is lack of consensus at what level we should start the screening program. And another problem, healthcare funding for screening program. That is very, very less. Then logistic constraints like man and material power for starting a screening apart from your clinical work. These are the few data from the Cancer Institute, what we have done in the this patients all surveillance endoscopy what we used to do. In that we have found some abnormal lesion on the white light endoscopy, subjected them for the image enhanced endoscopy, found low grade as well as high grade dysplasia, and we have done a early endoscopic resection of these cancers. This data is not complete, but whenever we are doing in the busy schedule, whatever we pick up on white light endoscopy, and we have done the procedure. The prevalence of this unhealthy mucosa, it may be very high, and we do all this. You can see the images of early cancers in the esophagus, and we take them for a endoscopic resection, and they are on follow-up. So, and we have done a study in Cancer Institute, colorectal cancer screening pilot study. The study is acceptability and feasibility of a screening test for colorectal cancer screening. Actually, we planned for a community-based study. Again, it is because of a lot of other factors, it is decided we go for a pilot study. Since the explanation is the incidence of colorectal cancer is less, that is 4.3 or 4.5 per 1 lakh. So why should we go for a community? That was the explanation. Anyway, we have gone for a pilot study. We have completed the study. The data yet to analyze the data. This is approved data. You can see we have taken 2,000 patients, of which we had 11 patients showing occult blood positive, of which mainly they were positive for fecal immunochemical test. What we are using routinely is fecal occult blood test, whereas fecal immunochemical test is more specific to detect the bleeding from the colon. So in our study also, in all the cases, almost all the cases, FIT was positive more than the FOPT. So for recommendation for future direction and improvement of screening, we have to discuss in detail before coming to a consensus whether what is the status, how to go about it, all these things. Then planning, at least we can screen a high risk group, identify the high risk group for the GA cancer, and we have to include the community engagement and policy recommendations has to be happen. And larger and community-based studies to evaluate the need for screening test is the need of the hour. And we have to train the healthcare professional for GA cancer screening. And we can collaborate with government, NGOs and healthcare providers to achieve this screening or surveillance programs. To conclude, GA cancers are on the rise. It is the time to think and take action for screening or surveillance. Nothing is more expansive than a missed opportunity. Thank you.
Thank you for your very good, nice presentation, very well balanced presentation. The topic is open for discussion. Any audience interaction?
Discussion at the end of the session.
Okay, we will have it. Please be
Thank you so much, sir. For our next interesting session, we have Dr. Malabari ma'am, who is the HOD of Medical Gastroenterology Department, Keelbach Medical College, to discuss on the topic NHCP or state prospectus.
Respected chairpersons, the organizers, senior faculty and my dear students, a very good afternoon to all. National Viral Hepatitis Control Program, our state perspective is what I am going to talk about. National Viral Hepatitis Control Program is a program under the Health and Family Welfare Government of India, and at the state level it is by the National Health Mission of every state. So, as all of us know that viral hepatitis is a public health problem worldwide, and WHO statistics showing around 1.3 million deaths, and the mortality of due to hepatitis B and C, the liver cirrhosis and cancer amounting to 95%. And India is committed globally for elimination of hepatitis B and C. This is part of the sustained developmental goal, where they have to reduce the epidemic of AIDS, tuberculosis, malaria and neglected tropical disease. And with this vision, the National Viral Hepatitis Control Program was rolled. So how did it start? Already it is an integration of services. Already we had a universal immunization program where hepatitis B immunization has been given to all the newborn, and then you will have a Swachh Bharat mission, safety of blood products and safe drinking water and sanitation. All these programs are already existing. What they did was they integrated all this, and then they launched National Viral Hepatitis Control Program in 2018, and it was by the Government of India, as I told, and for the state it was under the program of National Health Mission. So as I told, it is coordinated by the units at the center and the states. We have 3 units for management. One is the National Viral Hepatitis Management Unit at the center level, the State Viral Hepatitis Management Unit at the state level, and District Viral Hepatitis Management level. So the organizer structure, if you could see, it's a National Program Steering Committee. Who constitutes the steering committee? It is the Principal Secretary of Health and Family Welfare, and then DGHS, and all the programs coordinators of at the national level of RCH, Swachh Bharat Mission, all they will constitute the National Program Steering Committee. And then there will be technical resource groups where you can have experts in the field of medical gastroenterology, hepatology and microbiology, where they will give technical resource advice. And coming to the State Program Steering Committee, it is managed under the National Health Mission, the Mission Director. And you have a model treatment center, you have a state laboratory at the state viral hepatitis management unit, and at district level you have a treatment center. I'll go slide by slide here. So what are the key components is prevention. Prevention of hepatitis B, diagnosis and treatment of hepatitis B and C, monitoring the evaluation, capacity building training and research. To be simple, what happens is, this is our state perspective. Where do we stand in Tamil Nadu? As you see, this in yellow, the prevalence is around 1 to 1.5 of B and 0.16 of C. This is based on the population survey, National Health Family Survey 2015-16. So as I told, in Tamil Nadu, we have a state viral hepatitis management unit. Who are the functionaries? It is headed by the Dynamic Mission Director of the National Health Mission, and then it will be rolled over by the JDHS. Then you will have a state nodal officer, and at the state nodal officer, we have a program officers and consultants. They are all working for the National Health Mission, and you have a data entry operator and assistants to help them. What is our job? Our job is to technically advise and guide them, and to ensure supply of kits as well as the diagnostic kits and drug supply from the Government of India. We conduct monthly review meetings from all the districts. We collect, collate and analyze the data, and we conduct expert meetings. So integration at the state level, what we do is we integrate with the JDHS RCH. This program is running very successfully in Tamil Nadu because of one thing is RCH, we are very strong thanks to the Pick Me app. Today, in today's scenario, to get a birth certificate, even in a private or in a public delivery, you have to get registered in a Pick Me app. In this Pick Me app, mandatory screening of the AN mothers of hepatitis B is mandatory. So we are getting a very good data on 100% screening of hepatitis B in antenatal mothers, and all these mothers are advised to attend institutional deliveries and hepatitis B vaccination 0 dose for the newborn. So because of Pick Me app, Tamil Nadu is one of the states we are doing well in RCH. And then regarding high risk group immunization, we have a meeting with the nodal officer of dialysis, where we conduct expert meetings how to go about in reducing transmission during dialysis. And there's one more program with the TANSATs, where we do an integrated target intervention, where there is a NGO under the TANSATs. They will screening of prisoners. They will screen the prisoners, and with the help of NGO, they will give treatment and counseling, and they will refer to the concerned district nodal officer for treatment. We are having around 120 jail centers where this program regularly being done biannually. And then for Ministry of Social Welfare and Justice, we have de-addiction and rehab centers where also there is screening and immunization activities going on. Then they will be given a psychiatric counseling and reuse prevention syringe, where at least you can prevent the transmission for those who are IV drug users, and the narcotic supplements instead of IV drug use. So we have a model treatment center. This is Rajiv Gandhi Government General Hospital and Madurai Medical College. We have 2 model centers in our state, and the state reference lab is again RGGH and Madurai Medical College. Here you will have a nodal officer, you will have a pharmacist, you will have a data entry officer, and you will have a peer supporter, and then a state lab nodal officer, a lab technician and data entry officer. At the district level there are 38, so totally we have 42 treatment centers. At the district level we have 38, and here also you will have, it's a treatment center where they will do screening as well as supply of drugs. So you will have a nodal officer, a pharmacist and a peer supporter. At the district level you also have NHM coordinators. From the district hospital level they will collect all the reports. And the district maternal and child health officer, an ANM and BHM. So this program is integrated at all levels, where you have a integration with the RCH, you have integration with the dialysis unit, you have an ICTC and ART center, where along with HIV they also screen for BNC and psychiatry and NHM coordination. So it's integrated at all levels. You do screening and immunization, diagnosis and treatment, conduct monthly review meeting, consolidate the district report, and conduct camps in prisons and health camps. So I'm privileged to have a battalion of experts. There are 15 medical gastroenterologists as district nodal officer in this state, and here are these are all as follows. And we have an enthusiastic group of physicians who are district nodal officers, very enthusiastic. In fact, it's very infectious, their enthusiasm. They call up and they ask for all doubts, and they're doing very good job, I tell you, in all the districts, and the microbiologists. So this is some of the World Hepatitis Day observation day on 28 July. We conduct programs like that one, the last one is an NGO program we did with the NGO organization SWAM in Hyderabad, where we did screening of transgender. This side, Professor Kandasamy sir, he conducted along with the prison camp with the jail superintendent, and we have in Trichy and in Salem. So this will be regularly being done in on all World Hepatitis Day. So merits of the program: 100% screening in AN mothers, as I had already told about the Big Me app, and HBIG immunization. High risk group screening is going on because it will be integrated with other specialty. The demerits are, it does not advocate treatment of AN mothers. Once you screen the AN mothers, the treatment is only after the delivery. This is the protocol of the program. And vaccination of close family members. I think this is the biggest demerit because we do not attend to the reservoir of infection. And we do not vaccinate the close family members. This also doesn't come under the purview of the program. And hemodialysis unit, even though there are so many dedicated machines, we see a lot of wash area as a source of contamination, and there are problems in biomedical waste disposal and high risk group immunization and qualitative PCR. This here is only based ELISA based. So qualitative PCR is not available in this program. And reporting as I think we need epidemiologists and statisticians, because predominantly we have only clinicians in this program. But whatever said and done, when I was a postgraduate, treating hepatitis C was like an interferon. Now we are having directly acting DAAs, thanks to DAAs, here at the community level, even at a village level and a district level, we are able to screen and treat a patient with the directly acting viral level, directly acting antiviral drugs. So this ability to preventive diagnosis treatment, the basic healthcare unit, I think it is a huge step. Where in a PHC level, where a patient can get an hepatitis C drug, is a huge step towards diversifying and equality in public health care. So to conclude, National Viral Hepatitis Program was started in 2018 with the goal of elimination of hepatitis B and C. Their target was to screen 30 lakhs by the end of third year. But what happened was it was hampered by COVID pandemic. And Tamil Nadu is one of the top states in screening of AN mothers and delivering HBIG, Tamil Nadu and Telangana. And then the prevalence it has been increasing, the hepatitis B is 0.5 and hepatitis C is 1.1. The major concern is of course dialysis for us. So high risk group immunization is the key, and proper biomedical waste handling and decontamination dialysis unit can prevent hepatitis C transmission. Present here there is integration with TANSACs in prison camp screening and rehab centers, and Ministry of Social Work and Justice to improve high risk group screening, advocacy, capacity building. All this can be done at the center level, but it has to be perpetuated to the grassroots level for any program success. And this teamwork, I think, will pave the way towards the goal of elimination of hepatitis B and C towards by 2030. Thank you one and all for patient listening.
Thank you very much, Dr. Manali. It's an excellent exposition of information to the faculties as well as the entire the medical fraternities of gastroenterology regarding the National Viral Disease Program. And really, but for this rest of the program is an excellent one. Almost I think it has never on the forum in the previous conferences. I want to specifically highlight upon what is being conducted in the government setup. The National Viral Disease Program is an excellent program. It is being almost going into the community, as our patron said. You have to go to the community level, and we have peer supporters. They go to the directly to the centers where they collect the people, the positive, not only positive, but also other liver disease patient, chronic liver disease patient. They pick up the patient and bring to the centers. Just like a primary health sub-center level, what is happening in the sub-center level, now the BHMs are doing collecting all the all infectious diseases, just like that. Hepatitis B and C, and even you can take, actually we are planning to take the fibro scan to the community level. We have initiated a a project at a model village of Kallur village, which is adapted by the medical college, where we are going to take the fibroscan to the community and doing a mass survey of fibrosis, yearly fibrosis. Even though it is a difficult task of taking a very costly equipment to the community center, but it requires only a very small expertise. It doesn't require expertise at all. Just placing the probe and you can get the CAP score and KPA. So thank you very much for highlighting on this. It's excellent.
அடுத்ததாக குடலின் ராகங்கள் என்னும் தலைப்பில் பேச வருகிறார் மருத்துவர் மற்றும் துறை தலைவர் ராமானுஜம் அவர்கள்.
So first of all, I thank Dr. Katasamy sir and Dr. Shafiq, my classmate, for giving me this opportunity. The topic was given by none other than the musician Dr. Katasamy sir. So the raga, so the surgeons used to say the best music they hear is after a surgery the bowel sounds. So that is the raga for the surgeons here. So the bowel is known to make ragam, but now I know it's a final session and the raga associated, any speech will be Neelambari. So that supposed to induce sleep. But my topic will be just about about psychiatry, what you should know for gastroenterologists or the mind gut relation in a brief, very bird's eagle's eye view. So we all have these functional gastrointestinal disorders, and I used to say that Dr. Kandasamy sir is more psychiatry patient than me, because most of the I used to fight with the patient. So everywhere psychiatry they come at the last. So even in this conference also, after every speaker I have given the last slot. So the word functional gastrointestinal problems are very common, and most of the functional gastrointestinal case goes to the gastroenterologist. And you should know something about stress, and of course any physician should have the common idea about psychiatric illness. So we try to separate mind and body. In fact, we cannot. This was done by a great philosopher Descartes. He said that mind is different and matter is still the discussion. People think that mind is different from body. No, it's not. Mind is nothing but an organ of the body. So anything which affects the body, which still affects the mind, and vice versa. So that is one important thing I want to stress, is that I will highlight the later. But when you say the word, it's always, isn't it, when a physician doesn't able to explain what the patient's complaints, they say functional. So functional versus organic. So the word functional means it, even now they think that it is a stigmatizing word, and it is taken for granted as nothing is wrong in the patient. No, it is not like that. Patient is suffering and there are a problem. Please remember, the word function means a disorder of function, not that patient is malingering. He is not malingering. That means he is not voluntarily doing. So especially the young physicians want to know that function means definitely there is a disorder of function. So the word organic versus functional is a bad thing, is that it means that when a person is having functional, it denotes that nothing is wrong. No, the exact thing should be functional versus structural. That would be a better terminology. We used to say structural changes and functions. So when you are not able to see any structural abnormality, you name them as functional. But so vague GI symptoms are very common, isn't it? So like any medical field, I used to say, whenever a person is not when the physician is not able to explain all the symptoms of a patient, so there are only three possibilities. There is, the first and foremost is always there will be an underlying medical disease which you are not able to diagnose. That should be the first thing. And the third thing will be that this disorder may be due to a manifestation of a primary psychiatric illness like depression or anxiety. But the second thing which is very, very common is there is always an interplay between psychological factors and physical. So, for example, a patient is having irritable bowel syndrome, he is having some problem in the gut. There is a problem in the sensitivity or the neuronal signaling. But the psychological factors play an important role. For example, even in cardiology, you say if 100 patients are coming in a month for with myocardial infarction, all are not same. You cannot treat all as same. They differ in their sensitivity. Some people with severe anxiety will have worsening of their myocardial function. Similarly, the mind factors play a very, very important role in the gut, because as you know very well, gut is in fact the second brain. I used to tell my postgraduates, all the neurotransmitters in the brain are present in the gut, and all the drugs we give for psychiatric, they will have an action in the stomach, and any drug which is given for the gastrointestinal problem will have a psychiatric side effects. Yes, sir. The enteric nerve, the small second brain, and the brain is also the second gut, we can say. So, for example, peptic ulcer, there is a shuffle whether it is organic or functional. So, after invention of H. pylori, they said there is a structure, but still they say people with stress, the H. pylori grows more. So, the element of stress will always be there. And when we come to the diseases, we say there are biological causes, psychological and sociological causes. In all this, not only in psychiatric illness, even for diabetes, we can say there is a biological. I may be biologically vulnerable, and my psychological personality, for example, my sedentary lifestyle or my temperament, my personality will worsen that diabetic status. And the social pressure, for example, if I am living in an affluent society, definitely I am going to develop diabetes. So biological, psychological and sociological factors are very important in all disease. So in gastrointestinal problem also, consider too often we incline towards the biological. Even in psychiatry, we see the patient only as neurotransmitter. So it is not the case. We should also understand the person as a whole, the psychological factors and also the sociological factors. So coming to the gut-brain axis, so there is an afferent, there is an efferent, so there is a two-way communication. We won't study in first year MBBS, the physiology, there will be a question called limbic system. We omit that. So limbic system is the very, very important area that connects the emotions and memory, and that is that circuit called the Pepe's circuit. This connects with the hypothalamus. So our emotions, our thoughts, everything is connected. It's reflected in the body through the limbic system. So, and the hypothalamus not only secretes the adrenaline, it also secretes the steroid hormones. So, this steroid hormones and the corticotropin release hormone, everything, it is communicated to the body, and all our stress, it affects the body, and it also affects our gut. So, there are through the vagus, and there is an endocrine signal, and as I said, the neurotransmitters. Immune system, stress reduces our immunity. So whenever a person is stressful, our immunity reduces, and the gut is the largest lymphoid immune organ, you know very well. So stress alters the intestinal permeability and also the production of now we even have what is called as psychobiotics, bacteria given for mood disorders. We are developing that. So there was a conference on psychobiotics, like probiotics. So as we know, the mood and food, we used to have the sattvic food, the rajas food and the tamas food in our tradition. Some food will alter our mood. So and finally we have the Rome criteria, the functional GI, right from esophagus to the ANS, anorectal disorders. So these disorders, the psychological factors are very, very. Only one important thing I want to stress: whenever a person develops a small problem, his whole mind will be concentrated on that body. Say for example, itching. A person is having itching, he will always think about that area. If I am wearing a watch, if I am thinking, I will have the sensation. In physiology, we call it as habituation. So if we are wearing a shirt for 1 or 2 minutes, that sensation will be there. After a few minutes, we forget our shoes or watch unless it is ill-fitting or is creating some problem. This habituation fails to occur in some patients. That leads to problems like irritable bowel syndrome and all the functional gas. For example, and we have depression and anxiety, the primary psychiatric illness, they can manifest with mostly loss of appetite and all so many symptoms. So this is one important slide where I say when a person is having more than 6 symptoms, any symptom, the chances of functional is very high. So finally, we have the vague gastrointestinal symptoms. You evaluate fully, you rule out a pathology, rule out a primary psychiatric illness, and all you needed is ask the patient to not to focus on his body part. So vayatapathiye nenachittumna, the person will always be sensitive. So that really causes all the problem right from esophagus up to the anus. So just I want to say a small example is child. It had functional dysphagia, difficulty in swallowing. The problem, after all investigation, the gastroenterologist referred to me. The problem is that the child was having lunch in the school. So the teacher used to hurry. So so this child develops dysphagia, and it generalized that even in home it becomes conditioned that whenever it starts eating, the child develops sensitive. It becomes sensitive and develops dysphagia. So always take an important note towards the psychological aspects and never separate the body and mind. Thank you.
Thank you so much, sir. Thank you for making us understand that body and mind connection is more important. I now hand over the session to chairpersons for discussion.
Thank you very much, Dr. Ramanujam, for an exciting session of. I think it was more or less a complaints, everything, explaining about that. I was expecting that he'll be singing a song like this. வயிற்றுக்கும் தொண்டைக்கும் உருவமில்லாதது உருண்டையும் உருளுதடி அப்படின்னு கேதாரத்தை ஏதாவது பாடுவார்னு நினச்சேன். பட் அவர் ரொம்ப டாக்குமெண்ட். But it is excellent. Really, it's a wonderful session. And finally, we have come to the sessions that I think that we are running out of time. By concluding remarks from the organizing chairman. First of all, I must thank the Indian Society of Gastroenterology Tamil Nadu chapter, President Dr. Prem Kumar, and patron Dr. KRP, and Secretary Dr. Pramanayagam for giving this for the opportunity to conduct this a wonderful session of program here. And we are always working hard for this. My team, Dr. Shafiq, Dr. Papi, and my postgraduates are doing excellent job for all arrangements, right from the designing of the invitation and every page. They took a meticulous care for preparing this, and sessions also, right from the higher end like the liver transplantation program to the last session of the ragas of that. All this everybody contributed for it is Sulapana, it is Silpi Mari Silki. We did everything, and also the I want to first of all, and secondly I want to thank our pharma people. Their overwhelming response for it's a mutual understanding between the two, the medical fraternity and the pharma. If it is not a good rhythm between them, it's very difficult to conduct any program. And everything goes well, and finding out that particular site, and we are searching for the site. It's a wonderful environment, and also the people here are received very well. and we already planned everything for food and other accommodation, everything, and also for postgraduates. So everything, I think it was a marvelous journey, right from start from the previous when they were Poppy Madam, when I was out of the station, out of the campus of previous Madurai conference, they told whether we have to take it as in midst of my son's marriage to be conducted. I welcome you all for this marriage program and function for next month on 16th and 17th. So in order to that, I want to avoid that thing. But madam, no, we are going to take it. So it has combined with this, and along with the printing of invitation, I printed the marriage print invitation as well as everything. 2 in 1. So it is a wonderful experience. Really, it gave me a lot of experience. And with that, we conducted a similar annual conference at 2014 in RR in Tirunelveli. And at that time, I was very much alone. I didn't have postgraduates or assistant at that time. I just started the department. So now I have a strong hand like Poppy Madam and Safiq when postgraduate. So I think I done a good job and get appreciation from especially the sessions. I think every session they're sticking on to the time. I have almost come to the end. Sometimes usually spilled upon to next hour. So we are already the raga of gut started from their gut. Let us finish it, and I thank you very much, and I expect your blessings and things.
Thank you so much, sir.
I would like to thank Dr. Kandasamy and the team for the excellent conference on all aspects, academics and the culturals. Culturals, again, the team who danced, I think, excellent. And Dr. Kandasamy is a multi-talented personality, and I think we started singing. And also, I would like to tell you that Dr. Kandasamy told me he learned dancing from this troupe. I don't know, probably we didn't, we should have given a performance to us yesterday. So I would like to thank for Kandasamy and the team. Maybe I think you should call our secretary, Paramnayam, is there. I think I would like to call all the team members of Dr. Kandasamy here. Where's the president? Entire team, please join us. Yes, I think we should give a standing ovation to the team. Yes.
எடுத்துட்டு போயிருக்கேன்.
Thank you very much.
One second, wait, sir, one second. Sir, அப்படியே இங்க பாருங்க, போட்டோ பாருங்க. Sir. அடுத்த போட்டோ எடுப்போம்.
Last but not the least, the final comments were the senior-most gastroenterologist, Dr. Saknarayan sir.
I should congratulate the
Sir, consent, sir. I should congratulate Kandaswami's the wonderful hyper-dynamic team for conducting one of the best midterm conference I ever attended. That is number one. This is only a duplication of congratulations from our president and patron, Dr. KRP. The second one, we give full assurance that your eldest son's marriage will be another ISG conference without CME. Right? The third most important regarding our discussion, the two state conferences, the surveillance and the all vaccine program, we congratulate you for our not effort. You understand? But the question is, you keep it within yourself. You don't inform public sector people. What are you doing? You have to convey that message, at least like this, to various officially to see that it reaches every practitioner. Then only the program will be successful. Otherwise, it will be within 4 walls program.
Monthly we are conducting.
You are conducting. I have been appreciating. Everybody is appreciating. We have a good class. But the question is, it should reach every doctor who is practicing. The second one I would like to tell the vaccine. Hepatitis A vaccine should be given to even HPS-AG positive people. Why? Hepatitis A induces the liver direct necrosis. Hepatitis B does not affect the liver cell. It is only an antigen antibody reaction. It is being given both public sector, private sector. But hepatitis A vaccine still continues to be only an optional vaccine. For all, even HPS-AG patient, you need to give this. Otherwise, you may be successfully treating a chronic hepatitis patient, liver transplant patients, everybody. If you don't give hepatitis A vaccine, if he gets a commonest flu-like liver, that is nothing but HIV infection. He is going to die. Hepatitis A virus affects an injured liver worse than any other disease, even worse than cancer. That is the one, that one. Codalin excellent I heard from psychology. But the most important thing what is known is, of course, is farting. Everybody gets farting after 60 years, which is a common thing. Supragastric culture. Well, that's what I got to show yesterday. On another conference, I will probably in entertainment you put that. I will try to share with you. Excellent. After result, in what way we teach, we understand and then manage. That is the one. The most important thing is, it is not only the hypothalamus that is responsible. It is the centrotemporal region. Frontal, that is the most important psychology. And the gut is the most hypersensitive area which has more receptors. The reflex is going on in everybody. H. pylori, he said, H. pylori is in everybody. You, I, everybody. There are only few people symptomatic. So, we need to take care of the water. Next vaccine. Next understanding, everybody. So, let us communicate, counsel all our patients, spend more time, little more than seeing people, how many are outside. Please, convey this message to us. Thank you.
Thank you, sir.
Mementos will be issued to all whoever not able to find them, will be issued to the
I should congratulate my close friend Shafiq. He is the best timer who has finished the conference within the well expected time. Yes, professional timer. Thank you. Well done.
coordinating.